upper lip. Saphenous vein is also used to reconstruct the superior vena cava. Contraindications to harvest the saphenous venous graft is local area cellulitis, thrombosis of the saphenous vein, history of DVT in that limb, any venous circulation in that limb, and they establish very one.
Oh, please wait.
Please tell me what the fuck you said to Rio.
अरे अपू वो कैमरा ऑन है किसी नहीं वो कैमरा ऑन है
Hi guys, good evening.
Good evening, sir.
Good evening, sir.
How are you guys doing?
Fine, sir. Thank you.
Good.
Good, sir,
India suddenly woken up for teaching, huh?
That's the way it should be.
The cardiothoracic surgeons are all sleeping for 20 years, man. I'm very happy to see that everybody is part of the process because this is the way to go. Huh? This is the way to go. You know, sit at home and learn from your seniors. Very, very good. Did you guys have 2 lectures today?
yes sir
Yes, sir.
Oh my God. You must be tired then.
no sir
No, sir.
Yes, not at all.
2 lectures with what, 3 hours, 4 hours? I don't know how long. I saw the time seemed to be a very long time. And Dr. Rao gave both of them?
Yes, sir. Suresh Rao, sir.
Hmm. I know Suresh very well. Yeah. I met him last month actually. I was in the lounge in Dhaka airport. And I saw this guy sitting and I said, he looks very familiar. So I went and said hello and he was Suresh Rao. I know Suresh Rao very well from IX.
हेलो हाँ कौन हाँ अच्छा आशा आशा सिस्टर बोलिए ना
My Nikhil is talking in Marathi.
सॉरी मत बोलो आप तो पेशेंट की केयर कर रहे हो तो सॉरी किस चीज का है
Nikhil, switch off your microphone. We can hear your talk. Don't shout at the nurse.
Nikhil himself has kept the microphone on.
Oh, he deliberately wants us to hear. Huh? I think his wife is not in town. Otherwise, we would have heard some very strange noises. Good. So we've still got people logging in. I'll wait a little bit more because I think today we don't expect that many cardiacs to join us because I think people are tired. There's been extensive 2 lectures before this, so it's quite a long one. But slowly they will join. I've taken away the security so people can join even without me having to add them. 55. You've got 5 more minutes. Let's wait. Yeah. बोल क्या बोल 1 to 1:30 minutes. Yeah, that's very good. That's very good. Just give all appointments out. Are you doing Monday to Friday or are you doing Saturday and Sunday? 12 to 4:30. So I will keep. Okay, that's good. That sounds good. Okay. I'll see. I might give more dates and time because really there's so much backlog, so we probably have to catch up with that. Yeah, June is booked out completely. Chal, I'll see you. Let's go. Okay, are we ready? 6:57. Wait 2-3 more minutes. So two things when we start, just switch off your microphones, and the other thing is remind me to start recording. Okay. How many of you do endobronchial surgery? Nobody? Anybody does endobronchial surgery? I don't even know what is endobronchial surgery. Hello? Can you hear me?
The aorta stops us from going towards the back.
Oh, of course. Yeah, I forgot. That is true. That is true. I am not talking about transthoracic. I'm talking about endobronchial. But yes, you guys are all aorta and aortic valve and all that stuff. Once upon a time, I started cardiothoracic surgery because I wanted to do aortic surgery, honestly. And I did a fellowship as well, 1 year's fellowship in aortic surgery. I was training to be aortic surgeon. And then the stupid VATS and robotics came along and completely changed my life.
Oh, okay.
It's amazing how life takes you along a pathway that you never thought you would do.
Where about did you do your fellowship, Prof?
I did with Bob Bonzer.
Oh, okay, in Birmingham.
Yeah, in Birmingham. Bob Bonzer, I was his registrar for almost 1 year and then did lung transplant with him as well. And I don't know where life takes you, and then suddenly you find yourself into VATS and robotics domain, and then you can't keep up with everything. That's the problem. See, when you're doing all this high-end stuff, you have to unfortunately sacrifice some along the way. So I gave up cardiac to do thoracic. So, thoracic surgeon by accident, but really enjoying it. Yeah. Okay, so where are we? 6:59. 1 more minute. We'll just wait. More people are logging in, I can see. The weather is gorgeous in London. Beautiful.
Yes.
I was sitting out in the garden this morning and very, very nice. Beautiful.
Still, the breeze is so pleasant.
Yeah, it's very pleasant, actually. Nice. It's not cold anymore. That's the most important thing. It's been miserable last few months. Yeah, my gardener came and he's mowed all the lawn, so it's looking very beautiful. It's very nice to lie down here. Okay, so almost there. So we'll just wait for 5 o'clock. Are you in the hospital, Amina, or are you at home?
No, Prof, I wasn't feeling well, actually. I think I have got this
Really?
coronavirus, yeah.
Oh my God, I know, I saw that Neil is down with fever and all that. I've been following it on the group. It's terrible, very scary. Particularly with the loss of, these lives, it's too much. Cardiac surgeons losing life over corona is just crazy.
I saw, there are certain people like the cleaners and all that. I was on call on Saturday, this last Saturday, 24 hours. And the cleaners, they don't bother even they were coughing in the middle of the corridor. And
No, it's a big problem. It's a big problem. People have not understood the significance of, and particularly in the NHS with the lack of protective equipment, it's really worrying. It's really worrying. Yeah. Okay, guys. Good evening, everybody. Welcome to another session of thoracic surgery. I know you guys have had a long session today with regards to pediatric cardiac surgery. So I'm going to try and take you on another pathway, completely different. A lot of people wouldn't even have seen a lot of stuff which I'm going to talk. But it is important that you see what is possible. And this is actually a very important concept because like I was saying when we were doing that SVC lecture, that the cardiac surgeons made a huge mistake. They let go of coronary angiograms and basic diagnostic techniques, and unfortunately now they cannot claim it back. The same thing is happening on the thoracic side, but from the word go, we have as surgeons not let go of endobronchial surgery. we've kept our feet in, and we are controlling the endobronchial surgery, though the pulmonologists are trying very hard to just take it all away. So I want you to, look at it from that point of view. I want you to understand what are the potentials of thoracic surgery. There is so much work that you can do that you will never go hungry. That's the reality. You will always have work, provided you keep your horizons open, you keep your mind open to learn new things, and you will see a lot of different things that you can do. And each one of it has a different set of skills. So when most of us who trained in the UK, our bread and butter was lung cancer surgery. Of course, when I came to India, it completely changed and it became tuberculosis surgery. But if you just look at lung cancer surgery, we as surgeons are being crowded from all sides. We've got the oncologists on one side who are coming in with targeted therapy. We've got the ablation therapy, the radiologists coming in with all their ablation catheters. And we've got now the radiotherapists who are coming with stereotactic body radiation therapy, SBRT, and they are trying to take away even the stage 1A lung cancers from us. And so it is very, very, very important that you are sensitive to change. That's the thing. You must remember that if you want to survive in a competitive environment, then you need to understand that change is inevitable. Anything that you're doing today, if you were doing the same thing 15 years ago, then the chances are you'll be left behind. So it's very, very, very important to keep up to date with the change that is happening. You can either choose to evolve with time, you can choose to become, to learn new techniques, or you can choose to become extinct. And that is the reality. I think, on the cardiac side, we are facing this quite a lot. A lot of work has gone away from our hands, and the cardiologists are just jumping in and doing everything. So all the young surgeons who are on this forum and who are listening to me, I want you to understand that you must be sensitive to change, and you must learn all the new techniques that are available. So just because we are doing endobronchial surgery doesn't mean that we are, competitors. Actually, endobronchial surgery is the best place where pulmonologists and thoracic surgeons can become friends, and we can join our hands together in the hybrid OR and help each other do very, very, very complex procedures, okay? So with the onset of the hybrid OR, with the presence of Dyna CT, with the presence of all the screening devices and everything, and EMN and stuff like that, I think surgery has become pretty exciting and has changed quite dramatically from what it used to be 15 years ago. So what do you do in endobronchial surgery? Well, there are two types of procedures that you do in endobronchial surgery. One is, of course, the simple, straightforward diagnostic procedures. And then you come into the era of therapeutic procedures. So a lot of treatment can be done purely endobronchially. And I'll show you what is out there in the market, and you'll be surprised how much the scene of thoracic surgery has changed. And that is why, when people just talk about good old, thoracotomy and lobectomy, I want people to wake up and see that there is a lot of things that have changed, and you really need to keep abreast of all the new technologies. So when you come into the bronchoscopy era, one is normal bronchoscopy, which you do using either a rigid or a flexible bronchoscope. Then you've got the era of interventional bronchoscopy, which I will talk about. You also have something called as intubation bronchoscopy, where you use the bronchoscope in theater for guiding your endotracheal tube, for making sure your isolation is correct, etc. EBUS and EUS is another world. I've put EUS in this category, but really we want to talk about EBUS. So EBUS is definitely another world altogether where, a lot of progress has taken place, and now we've got some solid evidence backing the use of EBUS. And last but not the least, electromagnetic navigation bronchoscopy. Either it's called as EMN or ENV. Both of them are same structure, same terminologies. EMN means electromagnetic navigation, and ENV means electromagnetic navigation bronchoscopy. So quite a lot of things have progressed, and I'll try and take you into the details of all of these to show you what is available out there. So as I said earlier, we've got flexible and rigid bronchoscopies. There are three types. One is the simple, flexible, rigid, and now we are in the world of virtual bronchoscopy. So a lot of CT scans and the softwares have an ability to recreate the whole bronchial tree, and you can actually follow the pathway exactly as if you are doing a bronchoscopy. So very often you can pick up lesions and you can highlight smaller things within the pathway. And this is very important because when you operate and you have seen the virtual bronchoscopy preoperatively, you can anticipate problems, or you can anticipate complications, or more importantly, you can anticipate abnormal anatomy. That is why virtual bronchoscopy becomes very, very important. And particularly when we are talking of era of stenosis and things like that, the virtual bronchoscopy helps you to get a very clear, accurate idea of where to make your cut, where to do the anastomosis and things like that. The flexible bronchoscope that is available is the standard one that we use is 4.2 millimeters. This is the one, this is the processor of that bronchoscope. There is a whole, this is called as a video bronchoscopy. In the old days, it used to be ocular bronchoscopy, which means you put it to your eye and you looked in. Nowadays, almost nobody uses ocular bronchoscopes. Most of us have got this point which we plug into the system, and then all the image is up on a video. So what we are really dealing with is video bronchoscopy. There is a suction system in there to allow you to suck. There is also a procedure cannula, a procedure channel. So you can actually put in instruments through the channel and you can do procedures through the flexible bronchoscope. And I'll talk about it in great detail. So there are various sizes available. There's 5.6, 4.9. 5.6 and 4.9 are more of the therapeutic bronchoscopes where we are doing procedures through it. The 3.6 to 4.2 is more of a diagnostic bronchoscope. And then the smaller sizes that you have, almost down to 2.2, are more used in children and in pediatrics. And 2.2 is also used as an intubation bronchoscope down the double lumen tube. Now, I have put this whole range of numbers because numbers change depending upon the company that's making it. So different companies have different configurations. So really don't get stuck onto the number. Look at the bronchoscope head and it will clearly tell you what is the diameter of this bronchoscope. Okay. Not only do we have flexible bronchoscopies with fibers in it, because light is emitted down a fiber optic cable. But the problem with flexible bronchoscopy is that you have to clean it, and cleaning the flexible bronchoscope is a big process. It involves pre-cleaning, mechanical cleaning, then post-cleaning. There is a whole procedure, including taking care of the bronchoscope to hang it accurately. The storage is also important. So there are at least 6 steps in cleaning. The problem with that is no matter what you do, you will end up with some infection left behind in the bronchoscope. So nowadays, they have come up with a new technique, which is called as a flexible bronchoscope. So this is an UMBU bronchoscope. This is used by the anesthetists predominantly, but they have also come up with a bigger size UMBU where you can actually do therapeutic procedures with this bronchoscope. The advantage of the UMBU's bronchoscope is that it is a disposable bronchoscope. It is small, it's a disposable bronchoscope and comes with a small screen like this. So you don't need the whole tower, which I showed you earlier. All of this you don't really need. You just get back into the simple small screen and you can do a lot of procedures. Of course, complex therapeutic procedures can't be done with an UMBUs. So these are disposable single-use bronchoscopes, particularly very good when you're talking about the ICU, when you're talking about the theater. Guru Kiran, please shut off your microphone. So UMBUs is these are licensed for single use, but in India, I know that people use it for about 10 times. Not licensed, it's an off-license use. The other advantage of a disposable bronchoscope is a normal bronchoscope has got fiber optic fibers running down the bronchoscope. So when you bend it too much, the fiber snaps. And when a fiber snaps, you get black spots. So over a period of time, when more inexperienced people are using a flexible bronchoscope, they will end up with losing vision with each fiber, because each fiber is a pixel on the screen. So when the fiber disconnects or snaps, then you lose the picture. As compared to that, this flexible bronchoscope is based on optics rather than fibers. So there is a camera at the tip of the at the tip of that bronchoscope, and that is relaying an image down here. So there are really no fibers running down this bronchoscope. So no matter how much you manipulate it, you cannot snap the fibers. So the image remains constant. And again, with the technological advances, I'm pretty certain that these images will become more and more high definition, and you'll get better picture on the screen. So this is an area where a lot of people are still working on, and I think things are going to change quite dramatically. So this is an EBUS disposable bronchoscope. Intubating bronchoscope, this is my anesthetist, Dr. Sangeeta, and the whole team here. And intubating bronchoscope is used regularly in thoracic surgery setup. In my particular setup, wherever I work, no anesthetist will pass in a double lumen tube without checking with the intubating bronchoscope. So it is nowadays almost mandatory. It's part of guidelines which says that once you put in a double lumen tube, you must check it with an intubating bronchoscope. Come on, what's happening? You must check it with an intubating bronchoscope to make sure that your double lumen tube is exactly on the side that you want to. Particularly important when you're intubating the right side, because you need to make sure that the Murphy's eye is bang opposite the right upper lobe bronchus, and intubating bronchoscope makes it very, very easy to have a look. This is the one I was showing. This is an optical intubating bronchoscope. You can also have video intubating bronchoscopes where the whole image is transmitted on a screen, and it helps you to, it helps everybody to see what is happening within the bronchus. So what are the procedures that you can do with a simple bronchoscopy? We all know simple things like biopsy. So you have, here is the vision channel, there is a suction channel, and then through the same channel, you can actually pass in a guide wire with a forceps. The forceps can go in and take multiple biopsies. Of course, these are tiny biopsies, but they are good enough to give you diagnosis. And of course, you don't take a single biopsy, you always take multiple biopsies, not just from the lesion, but also from surrounding areas. The reason for that is when you're dealing with lung cancer, or you're dealing with somebody with a history of smoking, you have to think of carcinoma in situ. Okay, so that is why it's important to take biopsies from multiple areas of the mucosa. In addition to that, you can also, when you're dealing with infective cases, you can do what is called as endobronchial washings or lavage. So this is a lavage happening. We are flushing in fluid, and the fluid that is coming out is being sucked out and trapped into the, is being trapped into a specimen trap, and then that specimen trap is sent for cytology. It can be sent for microbiology, and separately for TB culture. So endobronchial washings are quite a good way to pick up localized pathologies which may not show up in a sputum culture or in a sputum cytology. So going right up to the periphery, you can pick up specific lesions, and it will help you to diagnose things. In addition to that, one of the tools available on a bronchoscope is a brush, and you can use this brush, and the brush actually abrades the mucosa. You brush it a few times, going forward and backward, and then pull the brush out. Actually, usually when we do that, we don't pull the brush out, we pull the bronchoscope out with the brush outside, because you don't want the tissue to be left behind in the channel. So it's quite important that you pull the whole bronchoscope out rather than the tissue out. And then whatever is there on the brush, you put it on a slide and do a rapid on-site examination, or you send it for histology, cytology, etc. So that's one tool available to you. We have what is called as a transbronchial biopsy, where on a bronchoscope, you can actually go across the tertiary and the quaternary bronchus and get into the tissue of the lung and take biopsies. And this can be done under C-arm guidance or under direct vision guidance, and you can get biopsies from various areas. Of course, the sensitivity of this biopsy is much lesser than a magnetic guidance biopsy, because here you're just going into the lung in a blind way and taking a biopsy. There is, of course, a risk that you might cause bleeding because you are going transbronchially into the area. So the sensitivity of TBLB is slightly lower, and nowadays we have much better techniques than TBLB to do biopsies. We have the concept of doing a transbronchial aspiration biopsy. Works pretty well for station 7, station 4, station 2 lymph nodes. where you go in and you try and push your needle across the carina. Usually good for 10, 7, and 4 if you really know exactly where you are going. But again, it's a blind procedure, so you got to be very careful that your needle is not getting into the pulmonary artery or things like that. So nowadays, pretty much all of this is going obsolete with the onset of EBUS. So very few there are still a few centers across the country where EBUS is not available. They still do TBNA, and it has decent sensitivities and specificities, but of course not as good as EBUS. So this is how you do. This is the technicality of doing an EBUS. Works very well for station 7 because you know that there is no major vessel there at the carina, and you safely go across the carina and take your biopsies. But the important thing is it's not just one needle. You've got to do multiple punctures to get multiple samples so that your sensitivity of your procedure increases. Bronchoscopic care is very important. Whenever we are using a bronchoscope, it is our device. It is very, very, very important to maintain the bronchoscope. There are various methods of cleaning available. There is pre-cleaning, mechanical cleaning, disinfection, and post-processing of a bronchoscope. I won't go into technical details of all of this, but just understand that really you got to wash out all the channels, you got to clean out everything, and then you got to mechanically, so that's pre-cleaning, then mechanical cleaning, then it goes into a disinfectant chamber. So there is a lot of things that you need to do when you have to take care of the bronchoscope. And particularly when the bronchoscope comes in the hands of an inexperienced person, you inadvertently, when they're manipulating the bronchoscope or when they're putting in probes or needles through the bronchoscope, they may actually damage the bronchoscope. And this is a classical example of a damage in the sheath of the bronchoscope where there are bubbles coming out. This is called as a bubble test that you do when you put the bronchoscope under water and you watch for that air coming out from the side of the bronchoscope. Your channel is straight, the air should come out from the end of the bronchoscope. Anything coming out from the side suggests that there is a damage to the covering sheath of the bronchoscope. Now, the problem with this damage is it will cause water to seep into the sheath, and more importantly, it will cause bacteria to seep into the sheath, which you cannot clean off. So there is a high risk of infection, cross-infection from one patient to another when you have a damage to the bronchoscope. So this has to go back to the manufacturers for repair, and they have to resheath it. So quite an expensive procedure. Again, whenever we use bronchoscopes, there is always a separate area which is used for cleaning the bronchoscope. There is a separate sterilizer for bronchoscope. It is a vertical hanging sterilizer where you put the bronchoscopes into. And then this is another device available, which is called as automatic flexible endoscope reprocessor. So you put it all properly into these channels so that they are not bent too much. And then you close it, and then it gets reprocessed with all the various chemicals, and then the bronchoscope comes out on the other side sterile. Storage of the bronchoscope is very, very important. When you've done all of this cleaning, you've got to make sure that each bronchoscope has its own area to be stored, and vertical storage is better than horizontal storage. So personally, in our theaters, we have vertical storage. So you hang the bronchoscope from a hook on the top. There are slots for 10 or 20 bronchoscopes, and you hang each one of them so that the fiber optic cable doesn't get bent and doesn't get snapped. So vertical storage is better than horizontal storage. So personally, I like my bronchoscopes to be stored vertically rather than horizontally. The most important thing, and particularly in this era of COVID-19, is that you are directly exposed to the respiratory system of the patient when you're doing a bronchoscopy. All the bacteria, all the cough and everything is coming and flashing into your face. I've seen a lot of, almost 95% of pulmonologists and even surgeons hardly wearing any protective equipment on their face. They will wear a glove, they will wear a gown, but surprise, surprise, they do not wear goggles, and they certainly do not wear a mask when they're doing bronchoscopy. So it is very, very, very important to remember that you have to take personal protection when you're dealing with bronchoscopy, because 95%, at least in India, there is exposure to tuberculosis, and then you will end up getting TB, and that's the last thing you want. So you got to be very careful, and particularly now with COVID-19 and patients in the ICU, you having to do bronchoscopy on these patients, it's absolutely mandatory that you do maximum personal protection. Okay, all right. So that's so much so about flexible bronchoscopy. Let's look at rigid bronchoscopy. The standard one that we use and a lot of people use is called as a rigid bronchoscope, Karl Storz rigid bronchoscope. There are various diameters of the Karl Storz rigid bronchoscope, almost starting with 9 to 8.5 to 6.5 and 5.5. There are various ranges between it. And depending on whether it's a male or a female or a child, we calculate the expected diameter of the larynx and the trachea, and then we decide which bronchoscope to use. Because if you're doing an adult male, you try to use the largest size diameter, which is 8.5, purely because you want to actually pass other instruments through it. If it's a straightforward diagnostic rigid bronchoscopy, it doesn't matter. But when you're doing a therapeutic rigid bronchoscopy, you want largest channel so that your instruments can go through it. And more importantly, the ventilation is also going through the same channel. So you don't want your instruments to block the ventilation. So it is important to choose the largest possible size for the patient's height and weight. So typically, if I'm doing a rigid bronchoscopy, I actually put a flexible bronchoscope through it to do my additional procedures. So I will use 8 to 8.5 for a male. If it's a female, I'll use 7 to 7.5. And then it depends on a child. You can go up to 4.5, 5. They're all various sizes available. But of course, the vision goes down. So this is all the diameters that are available. And there is an endoscopic system here. See where my arrow is? That's a telescope that fits into the bronchoscope. So that's a rigid bronchoscopy. But I take out this telescope. I leave this telescope in when I'm intubating the patient with the rigid bronchoscope. And then this telescope comes out, and then a flexible bronchoscope goes through it. And then I use the flexible bronchoscope to go deeper into the tissues to do a diagnostic or therapeutic, whatever else I'm doing. So the intubation is done with this rigid telescope. And then once the rigid telescope is, once you've seen the tracheal rings, then you connect this to a jet insufflator. So my anesthetist will give me a Lure lock. There is, if you look carefully, there is a Lure lock here, which allows me to connect the jet insufflator, and the jet insufflator will give me, you can set it for adult or pediatric settings, how much kPa you want to put it on, and then you give intermittent jet ventilation. So with that, you can actually do your procedure for much longer time and not have hypoxia. Remember this, when you're doing rigid bronchoscopy, you're sharing the airway with the anesthetist. So it's absolutely mandatory that you have a very good working relationship with the anesthetist, and the communication between the two is absolutely vital. The worst thing is when the anesthetist blows when you are using something like a laser. That's disaster, because you will cause an explosion in the airway. So it's very, very, very important when to tell the anesthetist to stop ventilating, particularly when I'm doing any diagnostic procedure and I want to biopsy. I don't want them to ventilate because that will push the blood deeper into the lung. And number two, if I'm doing laser and they ventilate, the oxygen in the air will cause a blast with the laser fibers. So whenever I am doing a therapeutic procedure, I will tell the anesthetist, ventilation off, OFF. I use the word OFF because underneath the mask, off can sound like on when they're listening. So it's very careful. You've got to be very careful to pronounce clearly ventilation off, OFF. And more importantly, don't forget to tell the anesthetist ventilation on, ON. Most of the times the surgeon says ventilation off, but forgets to say ventilation on. And by the time the anesthetist starts ventilating, the saturation is down to 60%. So it is very important to stop intermittently to allow the anesthetist to get the oxygenation up. And particularly when you're only looking, then the anesthetist can continue the ventilation. It's only when you're doing a procedure that you want the ventilation to stop. So very, very important to use the jet insufflator in a very judicious way. Okay. Now, I put in the rigid bronchoscope and I put in a flexible bronchoscope through it, and I do my procedures. One of the other techniques that are available to us for diagnosing or doing a lot of diagnostic biopsies is endobronchial ultrasound. So endobronchial ultrasound is a device which has got the bronchoscope in it. It has got an ultrasound element to it, and it has got a working channel through which you can pass in a needle. So using the ultrasound, you can actually do like an echocardiography, really, but a local ultrasound. So it shows you blood vessels, it shows you flow. You can also use color Dopplers to see what is the flow. Have you got an artery there? Have you got a vein there? And more importantly, it highlights to you lymph nodes. It's very, very sensitive for lymph nodes. So using the ultrasound, you can actually, the ultrasound waves, you can actually highlight the lymph nodes. Now, the problem we all know is air is a very poor conductor of ultrasound. It's a very poor conductor of ultrasound. So in the trachea, you've got air. And if the bronchoscope was lying in the air, your waves would never pass across the tracheal wall into the tissue. So you've got this little balloon at the tip of it, which you inflate. And when you inflate that, then all the liquid and then go across into the tissue. So you get a really good orientation and analysis of a lymph node or a vessel. So it is a much more safer technique than using transbronchial needles, because here actually you're seeing where is the artery, where is the vessel. If you do this in the airway, then it's called as endobronchial ultrasound. And if you use it in the esophagus, then it is called as EUS, which is esophageal ultrasound. So EUS is more or less the same like EBUS, except that it's a much larger channel scope, because obviously the esophagus can accommodate a bigger scope. The vision is all 30 degrees. Look at this vision. It's all angulated vision because you want to work on the wall, not straight on. Preferably, it's all angulated to work on the wall. And then you've got channels for biopsy, and then you've got channels for therapy. So things like endobronchial, endoesophageal, submucosal resections and all can be done through 2 or 3 different types of esophagoscopes that are available. But we'll focus on the EBUS. EBUS is of 2 types. One is called as a convex probe EBUS. The convex probe is here. This is the convex probe. And there's a balloon, which I told you, which lights up, which expands, and then the sound waves go across. This is very good for proximal tumors. Okay, very good for trachea, very good for paratracheal lymph nodes, excellent for subcarinal lymph nodes, can get into station 10, which are higher lymph nodes. You can also go up to the 2nd generation carina, so you can get 11, you can get other structures in that area. If there's a tumor at the hilum, you can go up to the secondary carina, and this size will allow you to do that. But beyond that, it cannot push its way further. So if it's a peripherally lying tumor beyond into the tertiary and the quaternary carina, tertiary and quaternary bronchi, then EBUS is a convex probe is no good because the size of it restricts it. So they have now come in with a new one, which is called as a radial probe. The radial probe is a much thinner bronchoscope. It's a much thinner ultrasound mechanism. And the fiber that comes out, which carries the ultrasound, is at the tip of it. And it gives out ultrasonic image at the tip. This gives out at the side. This gives out at the tip. So you can actually manipulate this bronchoscope into the tertiary and the quaternary carina and take a biopsy from much, much deeper using the ultrasound. So this is how we do that. You switch on this, inflate the balloon, switch on your ultrasound, and these are the images that you get. You can see vessel, you can see lymph nodes quite clearly. As I said, you can use Dopplers to see flow through the vessel. So it gives you an idea of what exactly is happening. The gauge needle is a 22 gauge TBNA needle. The working channel is a 2 millimeter working channel. You can insert the needle into the tissue and then apply suction. The suction will pull the tissue into the needle, and then you take the whole needle back and do what is called as a ROSE, which is rapid on-site examination. So you have to go in and out at least 5 to 10 times, and it takes you 20 to 30 seconds. So your yield goes up quite a lot, and then the whole sheath is removed out, the needle is removed out and put onto a slide. But the key thing is you need a really good histopathologist or a cytopathologist. The success of an EBUS program completely depends on how good is the cytopathologist. And most advanced centers actually have the cytopathologist in theater, sitting in theater with his microscope, with his array of some stains, and he will look under the microscope as the procedure is going on, and he will tell you whether the biopsy is adequate or not adequate. If it's not adequate, you go in and take more biopsies. When you do that, your sensitivity of your procedure goes up dramatically. So it is a teamwork where EBUS is concerned. Again, I told you radial EBUS works very well for distal peripheral tumors. So here it is going all the way to the periphery in the tertiary bronchi, and you can take biopsies using the radial EBUS. So it's just an advancement on the technology. ESTS, ERS guidelines, as well as ACCP guidelines have looked at EBUS and EUS in a very big way, and they have suggested that it has a sensitivity of 83 to 93%, a specificity of 97 to 100%. Okay, so when it comes positive on an EBUS, it is positive. The problem is when it comes negative, it does not mean that it is not cancer. So the specificity is very high. If it comes positive and you see malignant cells, then it is cancer. There is no two ways about it. There is also the guidelines have looked at restaging with EBUS after you've done chemotherapy, radiotherapy, downstaging, and then you restage with an EBUS. Again, the sensitivity and specificity is pretty acceptable to give you an answer as to what is happening in the mediastinum, and very, very good levels of accuracy. So now this has become the first choice of investigations. You have no longer any role for jumping in with a mediastinoscopy. If you have access to EBUS or EUS, that is the first investigative tool that you must use for staging the mediastinum in lung cancer. And the level of evidence is 1. Okay, so it's very important. It's no longer, maybe or could be, let's do mediastinum. You cannot. The guidelines are very clear. I explained it the last time when I did the lecture on ESTS ERS guidelines. Okay, what are the advantages of EBUS? It's minimally invasive and pretty safe. It's pretty accurate for mediastinal staging. It can reach almost all lymph node stations. A combination of EBUS and EUS can get you all the lymph nodes. 5 and 6 are very difficult to get with EBUS, so EUS can get to 5 and 6. 8 and 10, 8 and 9 are very difficult to get with EBUS. Your EUS can get to 8 and 9. Just for your explanation, 2 and 4 is paratracheals, R and L. 10 is hilar. 7 is subcarinal. 8 is paraesophageal. 9 is inferior pulmonary ligament. And then on the left side, 5 and 6 are sub and para-aortic lymph nodes. Okay, so this is just to recreate for you to understand what we're talking about. It is a very good alternative for surgical staging. Mediastinoscopy has gone down quite dramatically now, but there is a definite role for mediastinoscopy. And if you use it more and more in staging the mediastinum, eventually it has been proven that actually EBUS is a more cost-effective mechanism for treating lung cancer, because it has high sensitivity and high specificity, and you can very accurately decide whether the patient needs chemotherapy or surgery or a combination, whatever. The disadvantage is, of course, you use white light images. Sometimes the images may be suboptimal, but that's not so much of an issue nowadays. More problem is the false negative. If you get a negative on an EBUS, it does not mean that the mediastinal lymph node is negative. So you need to go back in surgically and biopsy these lymph nodes. It's very important. Again, there is a learning curve because you're not operating straight on. With EBUS, you're operating at an angle of 30 to 45 degrees to your left. So the movement, you have to learn, the hand-eye coordination has to be learned, how to move at an angle and get into the lymph node. It's not that easy. You really need to do a huge number of EBUS before you become good. And it has a low negative predictive value, we said that. But if it is negative, then it should be followed by mediastinoscopy, because you should not be operating on lung cancer without knowing what is the staging of the mediastinum. It is absolutely mandatory. And if you go to the ESTS ERS guidelines for staging the mediastinum, it is very clearly and very beautifully listed that in an order as to what is the order of the investigations. The first step is EBUS and or EUS. Second step is mediastinoscopy if EBUS or EUS are negative. Mediastinoscopy upfront if the EBUS has given you an answer and you need more tissue. And of course, if you have done induction and resection is being considered, then EBUS EUS is a step. And if that's not possible, then mediastinoscopy for restaging. So these are the guidelines. This is the pathway. This is the pathway that you follow. And this is a different lecture. This is the lecture on staging the mediastinum. And I've done this in the past, but I'm quite happy to repeat it with you guys when we talk about the mediastinum. But today we'll talk about endobronchial surgery. So the next available tool in your hand is what is called as an autofluorescence bronchoscopy, particularly very, very good for picking up subtle changes, dysplasia. In smokers, you need to know carcinoma in situ. You need to know where is the dysplasia occurring in these cancer cells. So there are chromophores called as elastin, porphyrins, and flavins, which are given to the patient. And these chromophores, when they are exposed to the light of the bronchoscope at around 400 to 450 nanometers, they change a color. So respiratory mucosa is green, and then dysplasia looks distinctly reddish brown. So very clearly in front of you, you get a picture and you get an illumination which tells you where exactly to biopsy. So autofluorescence bronchoscopy is good when you're dealing with smokers, when you're dealing with early lesions, because it guides you to where to, because when you're looking down this, you don't know where to biopsy. You may see hyperemia, you may see some reddish patch. If you don't see a tumor, then you don't know where to biopsy. The moment you get into autofluorescence bronchoscopy, look at the patch. It very clearly tells you where is the dysplastic. Can you see that? So this is a different light. We've used a different light source, and look at it. Very clearly it's telling you this is normal bronchus, normal epithelium, but this is not normal. Please biopsy here. So using autofluorescence biopsy, your sensitivity of dysplastic changes goes up. And that is why this is a good technique in the hands of a good pulmonologist. It identifies precancerous lesions. It can be used for follow-up of cancers. It can be used for restaging of tumors when they have had induction or neoadjuvant chemotherapy. And it can be used as a surveillance tool for patients who have had previous surgery for cancer of the lung. There is again a learning curve, but the specificity of this is low. You definitely need more biopsies because you're looking for subtle changes. You're looking for microscopic changes. And then if there is more blood or if there is bleeding into that area, then you will get refraction errors because the red color absorbs away all of these white light and it completely gives you a very distracted appearance. So the cost effectiveness is not yet been clarified whether autofluorescence bronchoscopy is a tool that can be used as a screening tool for lung cancer. Hence, a lot of people don't use autofluorescence as a routine. But in a high-end lung cancer center, you must have access to autofluorescence bronchoscopy. So this is all about diagnostics. Let's look at what are the therapeutic options available to us in endobronchial surgery. So the standard one, which all of you would have done probably at some time in your life or seen it, is removal of foreign bodies. And there is a whole variety of foreign bodies. People give, lectures and lectures on the type of foreign bodies that they've taken out. Teeth and peanuts and God knows what. The other things are for resection of benign pedunculated tumors. You can snare it via bronchoscopy using a snaring and a forceps. You can use endobronchial electrocautery for burning away small lesions. You can use endobronchial laser. You can use endobronchial cryotherapy as a therapeutic measure. You can use endobronchial argon plasma coagulation, and we'll talk about each one of these. I'll take you through everything. The one thing that people ask me quite often is, what is the bronchoscopic management of a bronchopleural fistula? Is there any role for endobronchial treatment for a bronchopleural fistula? The answer is yes. If it is a small fistula, if it's a very early fistula, then you have a scope of going through the bronchial route, identifying the fistula, and then you can actually block the fistula with various devices that are available. So the easiest way is, of course, to use a blocker. So what you're doing is, with a blocker, it's called as a Watanabe blocker, you just block away that segment of your bronchial stump. You just block it away so that no air goes across, no fluid gets into that, and it allows that small bronchopleural fistula to heal. So you're not treating the fistula, but you're giving it time to heal by blocking away that area of the fistula. You can actually inject the fistula with a few things. There are various things. You can use a blood patch. You can use glue. You can use Tissil. So there are various things available. Cyanoacrylate glue is used. Tissil is used. But the important thing is, when you're doing an endobronchial procedure and trying to inject glue, please make sure that you do not withdraw that catheter back into the bronchoscope, because with glue at the tip of that catheter, and you withdraw it back into the bronchoscope, the glue will block your therapeutic channel. And I promise you, your management will throw a fit. Has happened many times. I've seen a bronchoscope which costs about 15-20 lakhs being thrown away because they pulled back the catheter into the working channel of the bronchoscope, and that blocked off because the glue set in the working channel. So when you do these procedures, you put in the bronchoscope, put your catheter through it, and then pull the bronchoscope as far away as possible. Only vision. The bronchoscope is used only for vision. And then you inject the glue, and then take both the bronchoscope and the catheter, which is lying outside, together out. You have to pull it out together. And sometimes you have to clean the tip, or you have to snip the tip and then pull it out of the working channel. So it's very important to take care that you don't damage the bronchoscope. There is evidence and more papers coming off of use of a endobronchial valve for bronchopleural fistula, and I'll talk about that later. All you do is you block off that segment where the leak is, and what you do is you allow the fistula to heal. So you don't allow the forward flow of air, and whatever comes back, it's a one-way valve, so it only allows stuff to come back. So any collection there will come out, but nothing will go forward, and that will allow the fistula to heal. This is a post-pneumonectomy fistula. Look at this. You can see the stapling line here, and there is a nice little hole here. Sorry, 1 second. Again, this is a small fistula here. Again, you can see this foreign body. The problem is this fistula will never heal if these clips are here. So when you go in to do these things, you have to actually take away these clips. So what you do is you get your bronchoscope in, you take away all the foreign body that you see. You actually have to take away any sutures that are there. And then you pass a brush across the fistula. And what you try to do is you cause trauma to the mucosa. The reason why you cause trauma to the mucosa is because you want to create irregularity on the mucosa, so that when you inject the glue will set into these irregularities and will get attached to that thing. Galaxy J7 Next, just switch off your phone. Switch off your microphone, please. Hello. I don't know who this is. Galaxy J7 next. I can't continue a lecture if people are talking in the background. Just please switch off your phone. Are you listening to the talk or you're not listening to the talk? Switch off your microphone, please. Thank you. It really disrupts my thought process. How the hell do I get switch off for everybody?
It's on the participants, sir. Maybe you can mute off from there.
It's just, it's very annoying. Okay. Yeah, so you push your endobronchial brush onto the mucosa, you disrupt the mucosa so that the glue sets into the mucosa and then it stays there. One of the problems with putting glue is that it forms a little plug, but when the patient coughs, the whole plug gets coughed out. So you really need to brush up that mucosa to make sure that the glue sits. It forms like little fingers into the mucosa and then the glue sits very well. Coughing out the glue plug is not a problem, but if the glue plug goes to the other side by mistake while coughing, then you will cause atelectasis on the other side, and that is a problem. So that is why you got to be very careful that you actually brush the mucosa and then you spray the area with glue. And again, I said there are various things: cyanoacrylate glue, there is Tissil, a lot of other things. You can use autologous blood. Different things have been described in literature. But to be honest, the success rate of this is not very good. It works very well for very small fistulas. But very often when I've used these, I have found that a few weeks down the road, the patient coughs out the glue and then you're back to square one. But it is worth trying because the problem is the surgery to close a bronchopleural fistula is a big undertaking. So that's why you try and avoid surgery. So very tiny fistulas or small fistulas may buy you time to either the fistula close, or more importantly, it will buy you time for control of infection so that the patient becomes relatively asymptomatic. Your antibiotics start to act, so the patient is not very toxic, so that when you go back and do your surgery for that fistula, you may be able to get good success. So this is how you do that. There is a fistula underneath that, and I'm injecting the glue. That glue forms a little sort of blob there. I have, as you can see, some blood there. I've actually roughened up the mucosa, and that's how it sits there. So it covers the tiny bronchopleural fistula. And this is a technique that you can use sometimes to get away with in a patient with endobronchial problems, okay? Endobronchial fistulas. So what about endobronchial cautery and snaring? This is again a very easy procedure. You have the use of diathermy and you have various probes available. You can have various diameter probes, or you can also have a snare which can be connected to diathermy. So the snare will go around the tumor and you diathermize the base of the tumor. But these things work very well when it is a pedunculated tumor, pedunculated benign tumor in the lung, in the bronchi. If it's a sessile tumor, which means it's got a broad base, then snaring it becomes a real problem. So it works only it works well only when you can actually get around it and you buzz your way. So as you close the snare, you activate the diathermy, and the diathermy then cuts through the base and takes out the tumor. What are the risks of this was a previous slide, sorry. What are the risks of bronchopleural fistula? What are the risks of endobronchial diathermy? The risks of using electrocautery in the bronchus is bleeding, because you, as I showed you earlier, if it's a large area and you try to diathermize, you might get bleeding, and diathermy is not an accurate area, does not cover an accurate area. So you can get bleeding, you can get excessive cough because there's irritation of the bronchial mucosa. Sometimes you can get a fire, you can get an endobronchial, you use the diathermy and suddenly your anesthetist blows oxygen down there. oxygen plus a spark is equal to fire. You'll actually get a blast. There are case reports of blasts in the airway and causing endobronchial burns in patients. So you got to be very, very careful. Whenever you're doing any therapeutic procedure into the airway, you must tell them to switch off the ventilation. And I shout ventilation off OFF. And then, of course, there's a risk of getting an electric shock if your devices are not well insulated. So these are all the problems of electrocautery. What about endobronchial balloon dilatation? That is also a system that's available to us. You can use a manometry catheter or you can use an esophageal balloon. There are special endobronchial balloons available for bronchial stenosis, for tracheal stenosis, which you can go in and inject. You can use hydrostatic pressure. You can set the pressure and decide how much you want to do. The problem with this technique is you have to do repeated dilatations, but usually these things come back. Whatever you do, this is good for webs and things like that, but not so good for stenosis. So if you've got small problems, dilatation works very well. Or you've done a tracheal resection and following tracheal resection, you got a mild stenosis, you can use dilatation. But it never works very well for major stenosis or fibrotic diseases, and not a great idea to, you really have to repeat the dilatations over a period of time. Sometimes we use the endobronchial balloons for opening up stents. So after we have gone in and we have put in we have taken away endobronchial tumor and then we have deployed a stent, we pass in a balloon dilator through it and we open up the balloon to allow the stent to open up to its maximum capacity. And it's pushed the tissue out so that the airway opens up a bit more. So there are various indications, but remember, most of the times there's recurrence of the pathology and you might have to do repeated procedures or end up doing something more than just balloon dilatation. So let's look at lasering. That's another important aspect. I'm going to cover a lot of the lasering side of things. It is part of the ACCP guidelines, part of the BTS guidelines. Okay, use of relief of obstruction for intraluminal tumor because of terminal malignancy is actually part of the guidelines, and laser particularly has been mentioned in both the guidelines. ND-YAG laser. Okay, so anytime you use laser, remember you are using the guidelines to treat. Most of the times it's palliative, sometimes it is therapeutic. So let's talk about laser. Laser is an acronym. LASER stands for light amplification by simulated emission of radiation. So it's not stimulated, it's simulated. So it's amplification of the light by simulation of the radiation that happens. So you've got this spectrum of light in nanometers, and the lasers that are available are from CO2 all the way to excimer lasers. You don't need to know the physics much except to understand that it is all the various wavelengths of light. It changes. So the type of laser that you are using is actually at a different wavelength. Hence, the property of the laser changes depending upon what is the light zone that you're dealing with, the light spectrum that you're dealing with. Okay, so here you are, all these lasers. This is straight from a paper, very, very good paper, very well written, talking about endobronchial photoresections, and it talks about all the types of lasers that are available, from argon to CO2, talks about the wavelengths. If you want to know, you can copy this and say it. And more important is here, what is the depth of penetration? Okay, so CO2 has a low depth of penetration, so very good for surface lesions. And then you've got ND-YAG is the one that we commonly use, and ND-YAG has a depth of penetration of 0.5 to 1.5 millimeters. But the balance is between perforation and therapy. So it's important to remember that if you're going to be using a laser which goes deep into the tissue and burns out the cancer, then you have a high risk of perforation. It's very important to remember this. As opposed to that, the CO2 laser is only superficial. So the ENT guys in the oropharyngeal airway use CO2 quite a lot. They are very happy with this laser because there's a lot of sensitive things, deeper structures. We as thoracic surgeons use Nd:YAG. This is our preferred mode of using laser. Again, it has got a decent coagulating effect, but not so great cutting effect. Whereas CO2 laser has little coagulating effect, but pretty decent cutting effect. So when you're taking out oropharyngeal cancers, you want to cut it and slice it from the base. Whereas we want to burn back the tumor. So our indication is Nd:YAG rather than this thing. Again, I'm sorry about this this headline. That's a mistake. So why do we use lasers? What are the three qualities of the laser? There are three qualities which are very important for a laser. One is the monochromaticity, one is the coherence, and one is the collimation. Monochromacity means that whenever you use laser beams, all photons are with the same wavelength. There is no fluctuation of the intensity of the laser. So along the pathway of the laser, all photons have the same wavelength. So you cannot start with CO2 and end up with Nd:YAG or argon at the other end. They all stay CO2. I showed you the light spectrum. So all the photons stay at the same spectrum from the start to the end. The other thing is the rays of the light that come out are parallel to each other to infinity. So they can stay parallel to each other for as long as the rays can keep going. And more importantly, the collimation means there is no loss of energy over distance. So when you start at one point from the machine, which creates the laser, the energy that is created at the machine is the same energy that will come at the tip of the fiber. This way, you can actually calculate how much energy you're giving. So the safety of the device goes up dramatically. It doesn't happen that you're setting the machine at 40 and there's only 4 coming at the tip, okay? So collimation is a very important tool for us when we are burning back tumors. This is the paper again from Cope and Wang, who talks about it, and it's a very, very good understanding of why you use lasers. Whenever laser light hits the surface, very little gets reflected back. There is some reflection, but very little. But predominantly, most of it gets transmitted across. So most of the things about laser gets transmitted to the tissue. In addition to that, there is a few scatter waves, and the moment it gets transmitted, it gets absorbed. And when it gets absorbed, there is either heat formation, which burns the tissue, or it activates certain chemical reagents and reactions within the tumor cell, and it causes what is called as photoablation. It also changes the ionic state of the DNAs, and it can actually kill the cancer cell at an ionic level. So there are few pathophysiologies of how a laser acts. This is a CO2 beam laser. We said it can only go to a very small depth, 0.3, whereas Nd:YAG can go all the way to the tip. But the burning pattern of the two lasers is different. So the CO2, because it only comes to the tip, there is this burning pattern, whereas an argon goes slightly deeper, and there is always a zone outside of it, of its burning pattern. And again, an Nd:YAG creates a longitudinal zone of action, of energy, and there is always a surrounding zone. So you've got to take care of the surrounding zone. It's very important. It's not just about buzzing the tumor here. You've got to remember that there will be some burnout to the lateral sides because of the scatter waves. So because the tissue gets, the energy gets scattered, the burn can go laterally, and that is what causes damage to surrounding structures. So you have to understand the pathophysiology of each laser before, the physics of each laser before using it on cancer. Lasers versus stents versus brachytherapy, pretty good for endoluminal obstruction, but not great for extraluminal obstruction. And sometimes if there's a mixed obstruction, it's good for the endoluminal part of it. So lasers work very well only for endoluminal obstructions. not for extraluminal obstructions. So again, oh, come on, what's happening? Okay, so again, we've got Nd:YAG laser. These are the features of Nd:YAG laser. It's quite important. We use it predominantly in the trachea or the main bronchi. Very good for endobronchial lesions, for exophytic, means tumors which are falling out into the lumen. Very good for localized lesions, less than 4 centimeters. So lasers, whenever you use, there's a Mehta's rule of 4, and I'll tell you about it in a minute. Works very well for visible distal lumen. If it's completely blocked, then it's very difficult because you don't know what the hell is happening beyond the tumor. Works well for early collapse. So if the collapse is less than 4 to 6 weeks, it works very well. If it's a stable patient, always the FiO2 requirement should be around 40%. Coagulation profile has to be normal because bleeding is an issue, and the pulmonary vascular supply has to be intact. Okay, so these are some factors. You can take a snapshot of the screen, and whenever anybody asks you about Nd:YAG laser, just throw this out. These are all self-explanatory. I don't need to go into details of each of these points. I told you about Mehta's rule of 4. This is very good. In the exam, if you can reproduce this, I'll be very, very happy. This is the one that you have to reproduce, okay? So usually maximum length of lesion, 4 centimeters, duration of lung collapse, less than 4 weeks, life expectancy greater than 4 weeks. You don't want to laser somebody who's going to die tomorrow, okay? Procedure time should not be very long, so less than 4 hours. FiO2 during laser therapy should be less than 40%. Don't raise the FiO2. You will cause laser burns. Number of pulses between clean should be less than 40. Total number of repeat treatment should be less than 4. At least 4 people on the laser teams. But more important is these settings. 40 watts, 4 watts. If it's a contact laser, that means you're doing it from a distance, then 40 watts. If it's a contact laser, like a CO2 laser, then 4 watts. Pulse duration of the laser should be 0.4 seconds. Okay. Again, distance-wise, endobronchial tube lesion to around 4 centimeters. The fiber tip to lesion should be 4 millimeters, and fiber flexible bronchoscope to the tip should be 4 millimeters. Same point is making here that please do not keep the fiber tip close to the bronchoscope. You'll burn the bronchoscope. So pull the bronchoscope back. At least the minimum distance is 4 millimeters. In fact, most of us keep it at a centimeter away or 2 centimeters away, because the last thing I want is the razor to reflect back on the bronchoscope and burn the bronchoscope. So this is a good one. Again, take a snapshot of this. We will ask you in the exam, particularly if I give you a laser fiber, I might ask you some of these. And the one important point is the settings. I will ask you these settings. So you must remember what are the settings of a laser, okay? Again, self-explanatory. Now the next question, which comes actually as a question in the exam, comes as MCQs, comes as long question in the exams. What are safety factors for lasers? Very, very important. This does come in the exam. We always ask when we are talking about a endobronchial lasering. Most important thing, nobody in a laser theater can enter if he has not done the laser safety course. You have to be certified, and this course has to be renewed every 2 years. It's mandatory. You cannot even touch a laser machine if you are not laser safety certified. You cannot even be a cleaner in a laser theater if you don't know the safety certification of laser. Very important, okay? The other thing is there should be eye protection for all lasers, for all personnel. The last thing you want is laser to reflect off a surface and hit your eye, because you know that laser causes retinal damage. So nobody should be in theater, no matter how far, no matter how close. It's not just about the theater, about the surgeon and the anesthetist. Everybody in theater should have safety precautions, should be wearing the goggles. There should be no reflective material. So even the rigid bronchoscope that we use for laser is actually black colored. It's not silver colored that you have a normal rigid bronchoscope. The laser rigid bronchoscope through which we put in the flexible is actually black colored, so that no light hits the silver and reflects into the eye of the operator. So no reflective material. All the windows and all the glass surfaces are covered with a sheet. There is usually a roller. In our theaters, we have roller shutters. So the roller shutters come down and all glass surfaces are covered. Anesthetic trolley is also covered to make sure there is no reflective material in the theater. Okay, so laser can be done only in specialized laser theaters where all the stuff is available to protect all the covers. And most importantly, laser warning sign has to be there in theater. Not just in theater, but also outside theater. So there is always a sign at the top, and whenever laser switches on, the moment I'm firing a laser, those lights go up. So nobody can accidentally enter into the theater. In fact, the moment we are in theater and all the staff is in, we lock the doors. We do not allow anybody to enter the theater because accidentally, A, I don't want to be distracted by somebody walking into my theater, particularly when I'm firing laser. And B, I don't want somebody to walk in without protective glasses because they will get laser injury, and that's a disaster to happen. So all windows are covered. Nobody can peep into the theater. You know, the theater doors have these little windows. Those are the ones that specifically need to be covered because people peep into there to see what's happening in the theater. And minimum personnel, as I said, 4 personnel is what you want in theater, as little as possible. So minimum is 4. You've got to make sure that the patient is also protected. Okay, you don't think that just your protection is important. The patient can also get eye injury with the laser. So we always, the moment he's under anesthesia, we close the eyes, we tape the eyes, and then we put wet gauze, not dry gauze, because dry gauze will catch fire. If the laser hits it and it heats up, it can catch fire. So we wet the gauze, we put the wet gauze on the eyes, and then we put like swimming goggles. We put goggles. There are laser goggles for the patient. So patient is also put, though he is under anesthesia, you still put laser goggles on the patient. But you don't use those big ones that the surgeon uses. You use like a swimming goggle that you put on the head of the patient. So the patient has to be protected as well. A non-reflective bronchoscope is natural. We have 2 suctions on a laser set. One suction is for sucking at the tip of your bronchoscope. Okay, so one suction connection comes to sucking endobronchially all the secretions and everything else. But more importantly, at the proximal end of the bronchoscope, the rigid bronchoscope, we have 2 large cups which are placed next to the proximal end of the rigid bronchoscope to suck out the laser plume, because the fumes that are formed by the burning, they are known to be carcinogenic. And the last thing you want is you as a surgeon to be inhaling that plume and then having cancer 10 years down the road. So you have to take care of that. So you need a special suction for the laser plume. Plume means the smoke that comes out of the bronchoscope when you're doing that. And the most important thing, this is the most vital thing. No, there is actually a key on the laser, okay, on the machine. And until and unless I say ventilation off OFF, theater personnel will not turn on the key. Most protective method that you should use. So when you turn on the key, that is the only time that you can fire the laser. So before you can press the foot pedal as much as you like, the laser will not fire because the key is off. The moment I say ventilation off OFF, and the anesthetist has to tell me back ventilation off OFF. Until and unless the anesthetist tells me that the ventilation is off, that key will not go on. And then I will be able to fire. So very, very important, because if you push in a jet of oxygen when you are about to fire the laser, you will cause an explosion within the chest. And that's a complete disaster. There are papers out there which have been published where they have lost the patient because of endobronchial burns. That's the worst thing to happen, okay? So there is always a safety switch on the laser, and you never turn it on till the ventilation is off. And you never switch it back off till the ventilation is back on. So ventilation doesn't come on until and unless that safety switch is turned to off. So very important. It is all a teamwork. So your surrounding team also has to know exactly what to do when you're using laser. And the most important philosophy of laser is to use the minimum strength that is required for the most minimum duration for coagulating a laser. Don't use higher strength. Always start with lower strengths. Start with 4 and then see how you're going and gradually increase it if you need to burn more. Okay? Always. And don't do a prolonged press of the foot pedal. You must just do, recurrent presses. So buzz, 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 like using a diathermy. But sometimes diathermy we press for a prolonged period. In laser, you cannot do that. You got to do step by step so that you do not burn off the or cause endobronchial problems. So this is how a laser machine looks like, and this is where the key is. There is a key installed into the machine, and different machines have it in different places, but always it is in the front of the machine. And that is the safety switch. You cannot switch the laser on till the ventilation is off. And this is a laser fiber that we use. And in the exam, we'll give you this laser fiber. And then the discussion starts, okay? So we used to always keep this in our examination. And whenever I wanted to talk about lasers, I would give it to the candidate and he would hold the fiber and then I would ask questions about it. Now, these fibers are usually meant for single patient use. I'm not talking about single use. I'm talking about single patient use. So if you want to use this fiber on a patient for 3 or 4 sessions, then you put in the laser, use the laser, take it out, clean it up, put it in a pack, get it sterilized. But on the top of that, you write the patient's name because he will come back, 3 days later, 1 week later for a second session. You don't have to open the laser, a new laser fiber. You can actually use the same laser fiber for a few settings. Okay, so that's the way you save money and cost on the laser. So Nd:YAG is the most common laser used. It causes tissue vaporization and thermal necrosis of tumors. We always inhale and cautery debride as much as possible. So we try to reduce the volume of the exophytic tumor. And then we do the lasering to stop the bleeding and to burn the tissue back. And it's not just on table. In fact, the burn back happens over the next 2, 3, 4 days. So the patient starts to feel better over a period of time as the action of the thermal vaporization and tissue necrosis goes on for 48 to 72 hours. So the tumor will burn back over a period of time, not just on table. We can retreat the patient 2 to 4 days post-procedure for a second sitting if you need. All tumor types, you really don't decide on what tumor you want to burn. You can burn whatever you like with a laser. Laser is not dependent on the histology of the tumor. And you can go up to any location within the airway. I'm not talking about the far away peripheral things. I'm talking about the proximal right main bronchus, left main bronchus, and the trachea. And exophytic is usually more successful. Extrinsic compression usually doesn't work. And most of the times when we do lasers, we actually combine laser plus stenting. So I will use rigid bronchoscope. I'll put in a flexible bronchoscope through it, or I will use my rigid bronchoscopy forceps. I will try and nibble out as much as possible. Once I've nibbled out enough, then I'll put in the laser. I'll burn out as much as possible right to the periphery. And then once I know that there is enough space there, I will then fire a stent, and the stent opens up and applies compression to a tissue which is already having thermal necrosis going on. So over a period of time, the stent gradually opens up and allows the patient to breathe more safely. Relatively effective and safe. Of course, there are complications. You can burn through the tissue. You can cause holes in the airways. Perforations are there, but it all depends on experienced operator. You really need to know what is your limits of using the laser. And it only comes with experience. And of course, the risk of bleeding. But laser actually can be used to stop the bleeding. So it's sort of a catch-22. There is 10 commandments of safe laser usage. This is quite important. Take a screenshot of this, please. And when you write a theory paper, please write this in the theory paper. It talks about anatomical danger zone, talks about laser team, patient selection, rigid bronchoscopy, monitoring the patient, talks about firing the beam in parallel to the wall. Don't direct it into the wall, but direct it parallel to the wall. Talks about the settings of the laser. talks about what to do when bleeding happens. Don't ignore it, and terminate each procedure once you're happy. But make sure that when you finish the laser, you must do endobronchial suction of the distal area, so that you suck out all that secretion that is accumulated beyond the tumor, and more importantly, you suck out all the debris. And of course, you have to keep the patient into a recovery room. This is the answer we want in an exam when we want you to write about laser. So the DNB guys in India, please make sure you take a screenshot of this, okay? Because FRCS doesn't have long theory questions, but DNB does have. And so this is what you have to write. This is Dumons, and the paper is here. This is the paper that you're quoting. So you can safely quote this paper, and in this paper, Dumont has given these commandments, okay? Complications we spoke about, all of this is possible, any of this is possible, and you've got to deal with the complication as it happens. I spoke about laser plume and other things, and most importantly is a risk of injury to healthcare personnel, okay? So this is how a laser looks. Here's a tumor, and you're buzzing it, and you're trying to keep it back. Here is a tumor, you're buzzing it and trying to keep it back. Sometimes laser can be used for webs, so you can use the laser to make cuts into the webs, and it opens up the web, or you can now pass a balloon, endoscopic balloon, and open it up after you've cut it with the laser. So you can combine more than one technique to actually achieve the best results in the patient. So what about endobronchial stenting? Because laser and stenting is usually a part of the same pathology, I will just immediately jump into it. You have tracheal and bronchial stenting. What you do is you put in a rigid bronchoscope, as I explained earlier. Almost all the time, I want jet insufflation for oxygenation of the patient. I have a very good discussion with my anesthetist. We both know what to do. And then I put in a flexible bronchoscope through the rigid bronchoscope. First, I will biopsy. I'll do whatever is needed to understand what is the pathology. And then I will laser that area. So ND, YAG, holmium, whatever is available. I'll do hemostasis with the local adrenaline wash. So I use saline with dilute adrenaline, and I can wash that area. It causes vasoconstriction. But remember, adrenaline can get systemically absorbed pretty quickly through the bronchial mucosa. So make sure it's very, very dilute. And then I will fire the stent. Depending upon where is the pathology, I decide what is the size of the stent I need and what is the type of the stent I need. And I'll talk about that in a minute. So there are various stents that are available to you, and this is what it is. So you've got silicone stents. Look on the third column, the construction. So you've got silicone stents, you've got metal stents, and you have got nitinol stents, okay? These are the three main types of stents. So nitinol, metal, and silicone. These are the three main types. There are various sizes available, all the way from 9 by 20. 9 is the diameter, 20 is the length of the stent. You can have all the way up to 18 by 70, depending upon where you are going to use this, okay? So you can have tracheal stents, you can have endobronchial stents. Again, the length, you usually try and start off, if you're using a silicone one, you can actually shorten it to size. So you can open a bigger one and you can actually cut the silicone stent and use it for sizing. So you really need to know the length of the area that you need to cover. You must have a proximal landing zone, you must have a distal landing zone before you put in a stent. So you've got to calculate that either by specific measurements on endobronchially by using a long catheter, touching it to the distal end and pulling it back, and then finding out what was the proximal extent and measuring the distance between the 2 points. Or you can use fluoroscopy, and under fluoroscopy, you can pass the catheter distal to the distal landing site and then pull back the catheter, and that will give you a measurement of what is the length of the stent that you want to use. There are various types of stents. There are covered stents and there are uncovered stents. Covered stents work very well when you've got endobronchial tumor and you don't want tumor to grow through the mesh of the stent. So works very well for the trachea, works well for proximal main bronchus, but not so good when the tumor is distally beyond, because then you will block off one of the branches. So particularly in the right main bronchus, if your stent is going across into the bronchus intermedius, you really need to make sure that the right upper lobe bronchus is still patent. And if you pass a covered stent into the right main bronchus, ending into the bronchus intermedius, the right upper lobe will get knocked off. So that's why in those situations, you use an uncovered stent, or particularly when you're going further up into the bronchi, where there are a lot more bifurcations, you prefer to use an uncovered stent rather than a covered stent. So covered stent is all for proximal malignancies rather than distal malignancies. The problem with using uncovered stent in a proximal malignancy is that the tumor grows within the network of that stent. And then if you ever have to remove this stent, it becomes a nightmare because the stent becomes a part of the body, and it's a disaster actually. So that's why we use covered stents when we are talking about proximal obstructions. Stents are also classified as tracheal and bronchial. So depending on where you're using, or they can be tracheobronchial. Sometimes you use a stent with an arm going into the left main bronchus. That's called as a tracheobronchial stent. You can also use what is called as a Y stent, where the Y lies on the carina. So you cover the trachea and you cover the right main and the left main bronchus. Or as I said, you can use a tracheobronchial stent by cutting off one arm of the Y and just pushing the stent into the affected side. But there are also predetermined tracheobronchial stents available, which are already made either for the right side or the left side. Obviously, the right side tracheobronchial stent has an opening for the right upper lobe, but it's very difficult to get the positioning correct so that the opening covers the right upper lobe. You need great experience to be able to correctly position the stent. So this is a silicone stent, typical one with it has always got these little struts on the side, and the struts help to hold it against the wall of the trachea or wall of the bronchus. Always better to oversize the stent, because if you oversize it slightly, it hits against the wall and stays there. If you undersize it, then it will migrate distally. So not a good idea. Always try to slightly oversize the stent and work it. So this is a nitinol stent, and I told you this is a mesh. This is an uncovered nitinol stent, and tumor can grow within this mesh and cause ingrowing of the stent. So tumor ingrowth is a real problem. But if it happens, you can laser back the tumor. It's not a problem. So if suppose by chance you've used an uncovered stent, a nitinol stent, and the patient comes back with recurrent tumor, which is again causing obstruction, you can go in and use laser safely on this stent. It's not a problem. With a nitinol stent, you don't have an issue of the nitinol burning off. You can actually safely use a laser to burn off, or you can put in an endobronchial balloon and open up the endobronchial balloon to push the tumor out. So there are various techniques available which you can use. I won't go into details of each technique. It really depends on your own experience, but most of us use rigid bronchoscope. We put in a flexible bronchoscope, and through the flexible bronchoscope, we will first pass it beyond the tumor. We will suction everything out, make sure everything is clean. We will wash and toilet. And whenever I do a stenting, I always want the patient to be extubated on table. Very, very, very important. Sorry, this is post procedure. So once I put in the stent, I will pass the bronchoscope beyond the tumor. I will always make sure I suck out everything distally before I extubate the patient on table. This is how I would do it. This is a tumor, endobronchial tumor present there. I have put in a rigid bronchoscope, and with the rigid bronchoscope, you core out. So very often, purely by using a rigid bronchoscope, you can actually try to dilate that tumor or core out the tumor, and then use a mechanical grasping forceps to nibble out as much as you can. Once you have done a bit of that, then you can laser the whole thing, because with laser, you really need to know what's happening distal. It's very difficult to laser when you don't know what's happening distal. That's why before lasering, I prefer to do nibbling and trying to bring out as much as possible. Then once you've lasered, you do some more decoring. You take all the tissue out, suction all that rubbish that's coming in. Then you pass in a guide wire into the distal airway, and over the guide wire, you pass in your stent, which is carried on a sheet. Now it depends on what stent you're using. Usually enclosed within a sheet is a nitinol stent, and a silicone stent comes enclosed within a metallic tube, and you push the metallic tube into that area, and then you push the stent out with a trocar and an obturator. So the silicone stent will open up like that, whereas a nitinol stent comes pre-packed within a catheter, and as you go in with the catheter, you actually pull back your rigid bronchoscope and you start deploying the stent, and the stent opens up in front of your eyes. Again, if you're not happy with the deploy, you can always, with the nitinol stents, you have the ability, there is a purse string at the proximal end, you can actually catch the purse string, and what the purse string does, it collapses the stent a little bit, and you can pull it back or push it forward by holding with your rigid bronchoscope forceps at the distal end. So it's possible to reposition the nitinol stent on table. With silicone stent, you can actually take out the stent. It's not a problem. If you're not happy with the position, you just pull it out and take it out, and you can redeploy it onto a metallic tube. There is a setup on which you can just push it into the metallic tube and then redeploy it. The problem with this nitinol is that you cannot redeploy it. Once it is there, you can only move it proximally forward or backward a little bit. You cannot push it back into the catheter. Once it's deployed, it's deployed. Otherwise, it's wasted. Then you have to open another nitinol stent. And these are expensive business. So you got to be careful. You know exactly where you are. Two ways to do it. One is you do it under direct vision with the bronchoscope and the flexible bronchoscope. You deploy the catheter under vision. The other way, which some people do, they use fluoroscopy. So they use fluoroscopy and they mark out on the chest wall the area or the length of the thing, and they put pins, proximal and distal, and then using fluoroscopic guidance, they will actually open or deploy the stent to allow it to take care of that, take care of the obstruction. Okay, is this clear? Hello?
Yes, sir.
Yes, sir.
Did it make sense what I said? I'm
It is,
talking
sir.
fast because
Yes,
there's a
sir.
lot of things to cover, but this is quite straightforward. That's why it's not complicated. I'm trying to keep it simple. Okay, so far so good. That's why I've not got videos in and things like that. I want to actually explain to you what happens. Okay, let's look at endobronchial cryotherapy. That's another technology that's available to you for physically burning back tumors. This is how the probe looks. Here is your machine. Here is your cylinder of either nitric oxide or CO2. And then this is a machine on which you connect. These are the various catheters that are available. You have flexible catheters and you have rigid catheters, okay? So cryoprobes can be flexible or rigid. You use compressed gas, which is usually nitrous oxide or CO2, okay? And the gas is actually pressurized in the chambers, and there is an inner channel and there is an outer channel. So the pressurized gas is made to pass through the inner channel, and the moment it comes to the tip of the probe, it expands because the channel is narrow, and then when it goes outside, it expands, and any gas that expands cools. That is called as the Joule-Thomson's effect. Okay, so any gas under pressure, when it goes from one narrow channel to an open space and expands, it dramatically drops the temperature. And using that effect, you create an ice. And then the cold gas gets sucked back by an external channel. And I'll show you this in a minute. So this is how it is. Here is the internal channel, and the internal channel goes. Here is the compressed gas coming from the cylinder. It's coming out. The moment it comes out, it has space. It starts to expand. The moment it expands, it freezes. The temperature drops almost down to minus 89 or 90. Okay. Usually at the tip of the probe is cold. At the distal area, the temperature gradually dissipates. Okay. And the gas, whatever is finished, it goes back, gets sucked back by an external catheter. So at the tip of your probe, you will get this ice ball, and the ice ball causes the cryoablation of the tumor. You can also use this technology for taking tissue biopsies. So you can actually ice ball one area, then go ice ball the next area, and the tissue between it will get trapped on the surface of the catheter, and then you pull the whole bronchoscope out along with the tip outside. and whatever tissue is here will then give you a cryobiopsy. That is the philosophy of how cryobiopsy is done. These are the various probes that are available. The principle is not indicated for immediate debulking. So laser, immediately you can debulk. If a patient is acutely unwell, you really want to get the airway open, laser works very well. But cryo doesn't work very well in that situation because it works on regression of the tumor over a period of time. So it takes a week or 10 days for the tumor to slowly burn back and get necrosed and open up the area. So it depends on the vascularity of the tumor. Usually better vascularized tumor regress better with cryotherapy. If it's more necrotic tissue, that's not so good for cryotherapy. Works very well for microinvasion and in situ tumors. There is no combustion risk with this. So that's a huge benefit. There is no risk of fire. So just cold is the one that you use. And it's a mobile unit. So you can move the unit from A to B. It's very easy to go from theater to theater. The laser needs a whole setup, needs a dedicated theater for you to actually operate in. It causes devitalization, hence causes recanalization, and can also be used for endobronchial biopsy. And now there are new probes which can actually go across the bronchus and can be used for transbronchial biopsy. So cryotherapy is a good technique for using for biopsy. More and more pulmonologists are doing this nowadays. It can have a frontal freeze, so it can freeze in front of it, or it can have a lateral freeze or a tangential freeze. So the freeze this is the ice ball that is being formed, and the tumor will start to die with the ice ball over a period of time, okay? And sometimes you can also use fluoroscopy, particularly when you're doing transbronchial biopsies. The pulmonologists like to use fluoroscopy to guide where you are, to make sure that you're actually not in the pleura. The last thing you want is a pneumothorax. So you want to make sure that you're only within the parenchyma of the lung and not in the pleura. Advantages are there's better control of depth, okay, because this is a slow process. Slowly it goes, it burns off. It can be used in area of coated stents as well. The laser in a coated stent has a risk of causing fire because the coating may actually burn off, whereas cryotherapy is okay in a coated stent. It doesn't matter. It does not harm cartilage. That's the other thing. Laser can burn cartilage. It is less expensive than a laser. Around 7,000 pounds is the equipment that you need for setting up a cryotherapy program. It has got decent penetration. It can go deep into the tissue. There is no smoke, no plume. That is important. No carcinogenic tissues. There is fixation of the liquids and tissues. So depends on the type of tumor that you're dealing with. And most importantly, it can be used safely in cardiac pacemakers. Electrocautery cannot be used in cardiac pacemakers. Laser is neither, we're not sure about laser in cardiac pacemakers. Again, I'm very careful when I'm using lasers in cardiac pacemakers, but cryotherapy can be safely used in cardiac pacemakers. There is no combustion risk with a cryotherapy. And again, I said it's a mobile unit. Okay, so that's so much so about cryotherapy. Let's look at another form of treatment that you have available, that is available to you. It's called as argon plasma coagulation, APC. And if you remember carefully from your previous slide, the APC, the argon has it's very good for superficial burning of tissue and can work from a distance. So this is the machine that's available. And these are the various probes. You got different types of tips available for using APC. And this is the philosophy. It usually works very good for coagulation. It doesn't have that much of a cutting effect, but it has more of a coagulation effect. And argon is very, very good for stopping bleeding. So whenever you've got hemoptysis or things like that, in liver surgery, argon is used. Usually argon diathermy is used because you're cutting through the liver. You've got a large raw surface. You want to actually coagulate as you're cutting. So it works very, very well. And it's usually used from a distance. So you don't need to touch the tissue. So really, it's much more safer than using a laser. As I said, there are various probes. There are rigid probes. There are flexible probes. Completely depends on what you're doing and what is your option. Good for hemostasis. allows you to recanalize a blocked airway. It's a non-contact technique, so you do it from a distance. Superficial, it doesn't go deep into the tissue, so pretty good for palliative of an obstructive area. And you get a broad surface coagulation. With laser, you get pinpoint surface coagulation. With the APC, you get broad area. You can cover a very large area with this, even without worrying about it. So here is the various ablative procedures. Electrocautery, tissue contact is needed. Laser, you don't need a tissue contact. APC, you don't need a tissue contact. With cryotherapy, you need a tissue contact. You have to touch the tissue for that ice ball to touch the thing. And then variable depth up to 1 centimeter. But APC and cryotherapy are all superficials. So work very well for superficial tumors and for superficial hemostasis, particularly when you're for hemoptysis. Electrocautery is not very good because you cannot control how deep you're going. Because you're touching, you may actually burn through the airway and cause a pneumomediastinum or a pneumothorax. So that's so much so about burning techniques. Is it okay?
Yes, sir.
Making sense?
Yes,
Quite
sir.
straightforward, nothing
Yes, sir.
complicated. It's just knowing about these techniques, okay? So one more technology is available to you that's called as endobronchial thermoplasty. It's used for treatment of asthma, usually used for treatment of chronic asthma. There's a lot of data now coming who's talking about bronchial thermoplasty for asthma. They use RFA energy. So it's a probe which has got RFA attached to it, the airway distal to the main bronchus. So it usually works on the smaller peripheral airways, almost up to 3 millimeters. So you can really go peripherally and burn things. You can create a high temperature because of the RF things, and the high temperature disrupts the muscle. You're actually trying to disrupt the myosin function, and you want to relax the smooth muscle. That's what it is. It's for asthma. You don't want bronchospasm. And so it is used for as a therapeutic means for people who are being medically refractory, people who are progressing on the amount of medical treatment that is going on, or people who are not doing well on medical treatment. Bronchothermoplasty is now being touted as a new tool for relief of asthma, but it doesn't give you huge long-term results. At the moment, the data is still very early. And this is how you do it. You get in the catheter into the distal thing, you put in a guide wire, and the guide wire opens up. There are 4 prongs, 1, 2, 3, and 4. Can you see that? There's no tissue between it. And these 4 prongs create an RFA mode, and the RFA mode burns 4. So you're not doing a circular burn. You're doing 4 separate burns into the smooth muscle. So what you're causing is a disruption of the smooth muscle. Can you see that? These are all various probes, and they cause vertical burns rather than horizontal burn. So there is no risk of stricture formation. So you're not doing a continuous circular burn. You're actually doing vertical burns. And then over a period of time, you follow them up with repeat bronchoscopies and things like that. Okay. What about bronchoscopic ablations of peripheral lung tumors? So far, we've spoken about proximal lung tumors. What we can do for proximal lung tumors. This is a good paper. JTD has published it 2019. So it's a pretty recent tumor paper, and it tells you what to do when you have got tumors in the periphery. How do you tackle with tumors in the periphery? So you can use RFA ablation for tumors in the periphery, either a transdermal ablation or a transbronchial ablation. You can do photodynamic therapy. You can use EMN waves to burn these peripheral tumors. You can use thermal vapor ablation endobronchially, or you can do this new technique called as bronchoscopic laser interstitial thermal therapy. So far, we spoke about laser endobronchially, endoluminally. But here they are talking about using the laser for burning the parenchyma of the lung in the distal periphery. Okay, so this is a new technology. BLIT, it's called as BLITT. And some people may ask you about it. So we spoke about the other. Let's speak about endobronchial vapor therapy. How does that work? This is the machine that's available. This is a catheter that's available. Goes down your standard bronchoscope, and actually it creates. You have to dilate a balloon. Your catheter goes in. You decide what is the area. Here is a tumor distal to that area, you've already identified which segment the tumor is in, and then you dilate the balloon. So the balloon blocks off this area, and then you spray it with vapor. It's a guided vapor. It's not just your normal steam. It is vapor at high pressure and high temperature, and the vapor burns away the tumor. This therapy is also being used for asthma, but predominantly nowadays they're talking about using this as a technology for causing burns and heat ablation of peripheral tumors. Let's talk a little bit about endobronchial BVRS. Now, this is the most important thing, okay? Is this clear? So far, so good. Now, two more things left, which are quite important actually, and I'm going to spend a bit of time on it. BVRS, which is endoscopic lung volume reduction surgery, and EMN, which is electromagnetic navigation bronchoscopy. So emphysema can be treated by BVRS. The evidence is coming in now. More and more papers are coming in. There is no meta-analysis as yet, but there are a couple of trials going on, and I'll tell you about them. How do you endobronchially treat emphysema? You can either put in an endobronchial blocker and block away that distal area, which is emphysematous, or you can put in a one-way valve, and so the air cannot go in, but whatever air is trapped in the diseased tissue will come out. So the area will slowly over a period of time collapse. Or you can use coils. Coils create a fibrous reaction and cause collapse of the affected bronchi, and thereby the distal emphysema will start to collapse and you'll get collapse of the airway. Or you can open up a bronchoscopic, you can open up an emphysematous channel across the endobronchial tissue into the next segment. So whatever is emphysematous and bullous will actually collapse into the normal airway and come out. Okay, so it's called as an airway bypass stent. So let's look at each one of them. You also have options of using bronchoscopic thermal vapor ablation. This is for destroying the endobronchial tissue, which I showed you earlier for asthma. And for tumor, you can use the same technology for causing collapse consolidation of emphysematous lung. Nowadays, we've gone biological. You can use actually biological material within the bronchus. It's called as bio-LVR. This is new. This has not been published much about. So you actually block the distal airway with a biological material to cause collapse consolidation of the distal segment. So and then there is one more technique called as polymer LVR, called as poly-LVR. So these are two new technologies which are being used for BVRS. And the last, which is again a very new technology, it's called as targeted nerve denervation. So you get into the bronchus and you use an RF ablation energy to actually cut the nerves that are supplying that area. The moment you cut the nerves, the airway will collapse, and that there will be distal consolidation, collapse consolidation, atelectasis, and that will actually give you the desired effect for the patient. So this slide you must take on board. These are newer techniques that are used for bronchoscopic lung volume reduction surgery. These are not published in textbooks. Okay, these are all papers, and I've got you stuff from individual papers. So let's look at this. So the standard one we used to use over many years was Watanabe spigot. This is a spigot which is available. You go endobronchially, identify whichever is the segment, and just push in the spigot there, and hope that the distal area causes atelectasis and collapse and consolidation. But not very good, because frequently the patient used to cough out the spigot. You know, it does have some struts on the side to hold it into the area, but it's very difficult to get exact sizing of it. And it was an old technique, and the problem was not coughing it out. As I told you, the problem was if it went to the normal side, it will cause atelectasis on the normal side. And these people, emphysematous people, are already compromised. The last thing you want is problem on the other side. So it's an issue. So they really didn't work. Then we have got endobronchial valves. So endobronchial valves, you use it in two ways. One is either you deploy the valve, or you use what is called as a charting mapping for collateral circulation. So when you are going to put in a valve into a bronchus, you want to make sure that there is no collateral circulation, because what you're trying to do is stop all air going into that segment. If you have collateral circulation, which means there are openings from the other side, no matter what you do into the bronchus, that area which is distal to the valve will not collapse. And that is why you have a system called as Chartis, which actually helps you to map exactly the presence or the absence of collateral circulation. So you can decide whether it is worth putting in an endobronchial valve with this patient or not, whether he will get clinical benefit or not. So endobronchial valves are available, and valves can also be used for closure of air leaks. So now let's go into details of this, okay? So this is the first meta-analysis which has come through, 2015, where efficacy of endobronchial valves for advanced emphysema. And these are now starting to show benefits. So they have done a meta-analysis, looked at all the studies that are available. In fact, there are more studies now coming in 2019 and 2020, all of them suggesting that endobronchial valves are good for advanced emphysema, okay? So what are the standard valves available? There were two types of valves available. There was Zephyr and there was IBV. The Zephyr valve is a strut with a one-way system inside. And the good thing about IBV, which is the spiration valve, it has hooks on the side. So these hooks actually hook onto the bronchial mucosa and prevent migration. The problem with this is migration, because if they cough very forcefully, this valve will get thrown out. As opposed to that, this valve has hooks which go into the bronchial mucosa, and it has got an anchor pad as well. So this is like a fish hook. So you cannot easily cough it out. And the other good thing about the spiration valve is it has got a rod which you can actually, if you want to take out the valve in future, not leave a foreign body behind, you can actually go in and grasp this with a biopsy forceps and pull the whole valve out. This will of course cause a little bit of mucosal damage, but that is not such a big problem. It's really it's when you're doing it for air leak, and I'll talk about it in a minute. So this is the two valves side by side to show you what the two look like. The principle of this IBV valve is that air will come but cannot go through because this is closed, and all the secretions will come out from the side, and any trapped air will come out from the side. So no air goes in, and then this distal area gets collapsed and gradually becomes atelectatic, okay? And I'll show you a video of this in a minute. So this is how you deploy the valve under bronchoscopic guidance. All of these are deployed under bronchoscopic guidance. But before you do this, you have to do what is called as Chartis, collateral ventilation assessment. So what you do in a Chartis is you put in a bronchoscope, you put in a catheter, and you inflate the catheter. Once the balloon catheter is inflated, it occludes the direct flow of inspired air. And then at the tip of this catheter, you're measuring how much amount of air is going in, you're measuring how much amount of air is coming out, and more importantly, you're measuring how much is the airway pressure. The moment you close this, the airway pressure must go in, and the inspiration and expiration, inspiration and expiration should go down. So I'll show you this picture. Just see this video first, and I'll show you the graph. This is how you do it. You go into the bronchoscope. With a bronchoscope, you go into the affected area. You decide where you want to do BVRS. And then you can measure this. You can actually inflate the balloon and close off this. So now you're temporarily creating a situation that would have been created by the valve. And once you've done this, then the charting happens here. You've got all these chartings that are looking at, and the charting is like this. The expiratory airflow is orange. So the top part is orange. The inspiratory pressure is blue, okay? And the airway pressure is green. So whenever you inflate the balloon, no air will come out. So expiration should stop. Okay, but inspiration continues going there. So no air is coming out, and most importantly, the airway pressure is going up. So orange goes away, the green increases in size, but the resistance goes up as well. As opposed to that, so this is no collateral ventilation. If this happens, this is what is no collateral ventilation. But if you inflate the balloon and the orange is still continuing and the green is same, but no increase of airway resistance, that means air is coming into the distal area from somewhere else. That is the way you identify. So it tells you exactly what is happening distal to your valve or distal to your balloon. So eventually you'll be able to make a clinic. So this is a good patient to put in a endobronchial valve. This is not a good patient to put in an endobronchial valve. So this will fail. This will not fail. So let's look at the endobronchial valve and see how they put it in. A couple of videos. See, the hooks are hooking onto the mucosa and the valve is opening. And all the trapped air is coming from the side of the valve. And then gradually with fibrosis, all of this is starting to collapse, okay? And that is how you get atelectasis. If you need to remove, you put in a biopsy forceps, grasp it and just pull. And that will just come out with the thing, okay? This is actual procedure that we are doing. We are going in there. This is deploying a valve. Catheter going in. We are gauging the area that we need to deploy. We are measuring the size of the small airway. Gives you an idea that your valve is sitting snugly. It has to come within the 2 blues of that thing. Otherwise, it'll be too loose and it'll cough it out. And now the valve is being deployed. And there you are. And you never do just one valve. You have to do multiple valves to obstruct, because you have to go into each of the segments and try and block off as many segments as possible, because you're really trying to get about 30% reduction in the volume of the emphysematous thing. So you have to measure like this. See, it's important to measure. If it falls within the struts of the 2 blue, then this valve will sit snugly. If it does not, if it's a larger airway, the valve will just be coughed out, and that's no good for the patient. So you deploy more than one valve, usually 3 to 4 valves at a time. So it's an expensive procedure. Each valve is about 1,500 euros. So at any single time, you're deploying at least 10,000-15,000 euros worth of equipment in there, because it includes bronchoscopy and things like that. This is another valve deployment taking place, just to show you how it happens. Technically, it's a very easy procedure. It's not difficult at all. Anybody with half a sense of bronchial anatomy and anybody who knows how to do rigid flexible bronchoscopy can do it. This is done only with flexible bronchoscopy. You don't even need a rigid bronchoscope. And sometimes, so look at that. See the valve, the trapped air is coming out through the valve. So that's important. This is after the BVRS. We are doing a repeat bronchoscopy, and we want to have a look and see how well the area has collapsed. So as you go in, you can see this is collapsed. Can you see that? So this is a collapsed lower lobe, and there we are. Not lower lobe, upper lobe, and there we are. And these are all the valves sitting in there, 1, 2, and 3 valves. In this situation, you just leave it in, you don't take it out. But when we are doing for air leak, we take it out. Look at that. So over a period of time, it will just get collapsed and fibrosed. And then the whole thing will be a BVRS, okay? So this is how it is, a huge emphysematous area, and all of it is collapsed and consolidated. And so the normal lung, which was compressed here, starts to expand. And that is what gives you benefit of the endobronchial valves. We also use endobronchial valves for stopping post-operative air leaks. So how you do that is you go into the airway. You have a patient with a chest drain which has got a bubbling chest drain. You take him to the theater. You go into the theater. You put in your flexible bronchoscope. Get into the operated side, or this is not in an operated patient. This is in a patient who's got prolonged air leak. So you go into the operated into the side that has got the chest drain, and you collapse each of the segment with a balloon. The moment you inflate the balloon in the affected segment, you will immediately see a drop in the air leak. So the air leak will stop once the balloon is inflated, and that will give you an idea of where exactly to put in the valve. Can be used even in a post-operative patient as well to segmentally block an area which is leaking air, not the one that you've operated, but the rest of the lung. You don't know where the air leak is taking place from. You can get into the normal lung and try to find out, and you can actually put in a balloon, a valve, and that causes collapse atelectasis of that segment, and the collapse atelectasis allows that tear to heal. And then after 6 weeks, once the chest drain has been removed and patient is fine, you go back in and pull that valve out, and the lung can get back to normal. So it is a temporary technique to allow the lung to collapse and to heal over the area. So this has also been published in JTD. It's not actually, these are things that are still very much within the early use domain. So here you are, this is a thing, you inflate the balloon and you completely occlude this bronchus and see what's happening in the drain. The moment you know that the air leak stopped, that's the place where you deploy the valve. So these are the valves deployed, and you can very easily catch this and take it out 4 to 6 weeks later. Okay. So what are the problems with endobronchial valves? Migration is a big problem. They can actually migrate. You can cough them out. Blockage of the normal side is a bigger problem. The valve goes to the other side, and remember, it goes the reverse way. So if it goes reverse way, it actually blocks. Rather than allowing the trapped air to come out, it completely does not allow anything to go through. So that causes atelectasis on the normal side. And so the atelectasis can cause infection, or the valve itself can cause infection on the side that you're affected. Endobronchial coils are a new technology that are being used. There is more and more data coming through for use of endobronchial valves, but you have to use more of them to get the desired effect. And they can also be used bilaterally. Still used only within trials. It's not freely available in the UK. Still used within the trial. The important thing to remember is RESET trial. Okay, so they're looking at the use of endobronchial coils within the RESET trial. And this is the one that we want to know exactly how things are happening. Okay, and it has just come up with results saying that endobronchial coils may actually improve the quality of life for the patient. What you do in an airway bypass for BVRS is you identify the segment of the wall of the airway, and then you use a Doppler to make sure there is no blood flow in that wall or in that segment where you're going to make a hole. And then you fenestrate it with a needle and then pass a balloon dilator over it, increase the space of that communication into the next segment, and then you deploy a paclitaxel eluting stent, something like this. This is what it looks like. And so what you're doing is, what was an affected area, you're effectively giving it, allowing it for the trapped air to go into the next segment and then be breathed out. Because in this segment, the elasticity is not so good, but in the next segment, the elasticity may be still maintained and the patient will be able to breathe out, and thereby the lung will collapse because the trapped air or the residual volume will actually go down, and that might help the patient. Again, there are a lot of issues with using this airway bypass. The stents usually get occluded by granulation tissue. Stents get lost in the parenchyma of the lung. There can be exacerbation of COPD, pneumothorax infections, and really the benefits were not very clear. So airway bypass stent almost is given up in Europe. Nobody actually uses it anymore. But for theory, you need to know about these things. Thermal ablation, we spoke about. Distally, you burn the thing with hot air to cause a collapse consolidation. Biological agents that are used for bronchoscopic lung volume reduction are biodegradable products. They actually die away with time. So with stents, they stay there for life and they may cause infection. Biodegradable products actually burn away. So you can actually use blood patches. There are various blood patches available. You can use a fibrin plug in the distal area, or you can use a new device called as hydrogel. This is a hydrogel plug which goes and blocks the bronchus, but over a period of time, it dissolves away. So it doesn't stay there. And there is a new system called as Aeris Seal system, which uses a polymer. And this is a dissolvable polymer, and it's called as poly-LVR. So this is a new system that is available for bronchoscopic lung volume reduction surgery. And then this is the latest paper which has come out for targeted denervation. So what they're doing is they're getting into the bronchus and they're using RF ablation to cut off the nerves. These are the neural things that are getting cut off. And because the nerves are getting cut off, there is bronchospasm of that diseased area, and there is lung volume reduction, collapse and consolidation of that emphysematous segment. And this gives rise to BVRS. So this is something that is being spoken of and being done nowadays. Still experimental, but will be in normal domain soon. Okay. Are we okay, guys? You're still okay? Can I continue to EMN?
Yes, sir.
Yes, sir.
Okay, so this is the last phase, but this is quite important. This is the new baby on the block, really not really new. It's been around for a little while, and I'll talk you through that. So whenever you have a lung nodule, there are many pathologies, particularly in the periphery. It's sometimes very difficult to get a biopsy. If it is here, it's okay. But if it is here, what do? You can't get a CT guided biopsy because it's right in the medial side. So you have to do what is called as waitful watching. Or if it is, central, traditional bronchoscopy can only get to here. That's the problem. Radial EBUS can stop here. It doesn't go beyond. This is not possible by radial EBUS. So somewhere here, up to the tertiary, it's okay. But into the quaternary bronchus, the radial EBUS is no good. Cannot reach out there. Transthoracic needle aspiration cannot reach here in the quaternary or in the medial surfaces. It's very difficult and depends on the technique that's available. Surgery is an option, but really to do a surgery for a solitary pulmonary nodule is a disaster without histological confirmation. So that's why they developed the EMN system, which is the electromagnetic navigation bronchoscopy. So not for the close-ups, but for the really distal tumors in inaccessible areas. Into the quaternary and even beyond the fifth and sixth subsegment of the bronchial tree, the EMN can actually get into that area. So you start with a spiral CT with a thin 1 millimeter cut. The spiral CT is then uploaded into a navigation system, and the navigation system then recreates what is called as a virtual bronchoscopy. And the virtual bronchoscopy does anatomic registration on the EMN machine, and a 3D CT image is recreated, and it gives you a pathway to go into the distal airway. So what it does really is, it's called as, let me just come here. What it does is it actually creates a satellite-based direction mapping. Okay, so it is actually based on sat-nav. So what happens is, if this is a tumor here, the tumor and your bronchoscope, the tip of the bronchoscope has a magnetic probe which actually sends back signals to your main satellite. So this is the satellite, and the tip of the bronchoscope is your car. And by electromagnetic navigation, the system creates a pathway to go into the distal bronchus. It actually creates a pathway to tell you where exactly to go. It actually tells you what's the next road. What's the next road? So it's exactly like a GPS system. And I'll show you that in a minute. Okay, let's see the video. This is how it looks like. These are the machines that you've got. This is the edge technology that you've got. This is the probe. There is a super sensitive magnetic device at the tip, which is working like a GPS for guiding you into that pathway. So let's look at the video. Sorry, just 1 second. So this is how you how you plan the procedure. So the CT of the patient is uploaded into the system. The system identifies the CT, you do a 3D reconstruction, and then it recreates a virtual bronchoscopy for you to go in. So look at here, we are targeting that. We are telling the system that the tumor is here. So the system doesn't decide where the tumor is. You have to tell the system where is the tumor, and then it will create a virtual bronchoscopy. Watch that happening. This is a real patient. So it has now calculated what is the shortest pathway. Okay, through the virtual bronchoscopy, it has said this is the shortest pathway. Exactly like GPS, it actually calculates which is the shortest pathway with the least amount of bend. What you don't want is bends, because bends will then actually make it difficult for you to manipulate your catheter. So it tries to go the straightest path into that catheter. And here is your sensor. It tells you that this is where you have to go. And then when you reach there, it tells you go right or go left. And you keep watching this on the screen through the virtual bronchoscopy. So you can actually do this procedure a day before in a virtual way, and then go in and do the procedure on the patient. So this mapping is very important. The mapping is what leads you into that. And then you learn how to do this, okay? So it's quite important to understand this. One small video just to show you. And the part, it's called a super dimension edge. This is produced by Medtronic, and Medtronic are the ones who are actually pushing it quite heavily. At Barts, the system that we have is a Medtronic Covidian system, and they are the ones who are actually supporting this technology. Again, similar, I've spoken about this earlier. Okay. So it is a technology which is used for enhanced visualization, for accurate modeling. So a 3D construction can be created out of a 2D imaging technology that you've done. It compensates the CT to the body divergence. So whenever you have a 2D thing and your body is different, it actually compensates for the difference between the two and gives you correct navigation. And it allows the catheter position in relative to the nodule. The most important thing is the catheter has to go right into the center of the nodule. And that's what it allows. And even goes for really small nodules, up to very, very small sizes, like 2 or 3 millimeter nodules, you can get into there. Smaller the size of the nodule, less is the accuracy of the thing. So you really have to be careful about that. You can do a callback, or you can record your pathway. So also for medical legal, this is very important. You can save it and you can use it for medical legal advice. So EMN is used for diagnostics, as we just saw, or it can be used for therapeutic as well. So the diagnostics are for peripheral lesions, lesions covered by scapula or by ribs, where you cannot do a CT-guided biopsy. Mediastinal lesions, which means on the mediastinal side of the pleura, where your CT-guided biopsy needle cannot go. And for very small GGOs, okay? So really tiny GGOs can be accurately localized using the EMN bronchoscopy. You can do multiple biopsies of the same lesion. So, your guide catheter stays in place. The tools can go in and out. You can use a brush, you can use a needle, you can use a biopsy forceps. So the guide catheter is locked into place and multiple tools can go in and out of the same lesion. More importantly, multiple lesions can be biopsied at the same time. So it's a pretty good tool for giving you biopsies of multiple GGOs or multiple nodules. And it works very well for mediastinal lesions. We're talking about mediastinal lesions on the mediastinal surface of the lung. We're not talking about mediastinal. There's less risk of pneumothorax. That's the other thing that you have to remember, that, because is guided, you're not going through the pleura. You're staying within the pleura all the time. This is really, really a good tool for the tiny peripheral lesions. So what are the therapeutic ENMs? So once you have diagnosed this tumor, you've taken a biopsy, the biopsies come back positive. How does ENM help you with surgery? Because these are tiny nodules that you're picking up, and to really feel them do it by VATS is a very difficult position. So what you can do is, once the catheter is locked into position, you can actually inject that little nodule with a dye. And when you go in by VATS from the side, you can actually see the color very clearly and tells you, pick this tissue up and wedge it out. So it's a way of biopsying. You can leave a metallic marker there, so you can actually, under fluoroscopic guidance, understand where is the metallic marker, pick up the lung tissue and wedge it out. Or you can put in a coil there. Coil again is radiolucent and radiopaque, and it will tell you exactly where to go. It can also facilitate SBRT. So, if you put in a coil there on the SBRT, if somebody wants to give SBRT to that small tumor, then the marker will help you to plan your CT and plan your radiation dose. Some people are talking about using a glue. So what you do is you go into that small lesion and inject the glue. The glue will be felt as a hard nodule. The problem with the GGO is when you go by VATS and you palpate with your finger, you cannot feel the GGO because it's not a nodule as yet. Whereas the moment you put glue into it, these glues do not destroy the histology of the GGO. So they can be actually, once you take them to the histology lab, you can dissolve the glue away and have the normal histology retained. So the stuff that they use is not just normal glue. These are all special chemical agents which form a nodule, but they dissolve away on histology. And now the latest one is the RFID chip. And I'll talk about this in a minute. So you can actually fire an RFID chip into the GGO and then come in by VATS from the side. And the RFID chip, exactly like in a supermarket shop, you have these barcodes. So the RFID chip has a barcode. So when you put a scanner by VATS on the surface of the lung, the RFID chip will start to beep, and you will know exactly where is that RFID chip. And you pick it up and you wedge it out and send it for histology. And in histology, they'll cut open, throw away the RFID chip, and process the tissue. So you can put multiple RFID chips and biopsy multiple GGOs. And all of this is done in the hybrid OR. You really need hybrid OR. And the technique is called as IVATS, okay, image guided VATS, which means that you use EMN to highlight the nodule and then go by VATS and you biopsy all these nodules. And most of this is now being done by single port IVATS, okay, and this is being published now. Calvin Nug is one of the guys who's doing a lot of it from Hong Kong, and Calvin from Bart's Eye Hospital is also publishing quite a lot on this technology. And these are the two guys who are leading the world of EMN. So this is what you mean by the blue dye. So you go in by EMN, you inject a dye, and when you go in by VATS, you know exactly where to wedge out. You do not have to even feel this area. You just wedge it out and take it out, and you know you've got the correct small biopsy. You can also use your things to put in a guide wire, and the guide wire will tell you where exactly to biopsy. That's another technology that's available. You can put in fiducial markers. You can see this, and the fiducial markers will tell you where to plan your radiotherapy. It's a good tool for radiotherapy for fiducial markers. So look here, you've gone in with the EMN, your catheter is in there, you have actually fired the fiducial markers. And when you go into the radiotherapy suite, you can actually plan your radiotherapy. This is the area that I want to take out, and that is what's going to get rid of the GGO. So it's quite a good one. And then the new one, which got released late last year, was the RFID chip. Hiroshi Date and my good friend Sato. Sato is the guy who's actually done most of the work on this. They have developed this chip. So you go in by bronchoscope, fire the chip, and then you go in by a thoracoscope, and this is a probe, and the probe goes in, and you start, it beeps when you see the RFID chip, and it gives you an idea exactly where is the GGO. And you can take it out in the hybrid OR and then do whatever you want to do with the specimen. So it is quite good for excision of the specimen. You can also do therapeutic ablations by EMN guidance now. And this is the new baby on the block. You can use RF ablation under EMN guidance, and you can put in an RF ablation probe and kill the GGO, kill the cancer. And now you have now come up with microwave ablation. So Barts is one of the first hospitals in the country. Kelvin has done this work, and he has done a number of cases with microwave ablation of a GGO. Endobronchial treatment of lung cancer. You have an option for this technology to develop into localized radiotherapy or localized intratumoral chemotherapy. This technology will help you do all of this. And these are the papers which are coming out, pretty recent papers which are now talking about all these technologies. So this is the RF ablation catheters that are used. There's a multicentric trial going on for microwave ablation at the moment, and they will publish soon. This is how it works. The probe goes into the tumor and the microwave ablates the tumor into that area. You can also use the same technology for endobronchial radiation or intratumoral chemotherapy. So there are many, 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 many advances that are happening in endobronchial surgery. And, you really need to keep up to date with everything. You've got to keep attending meetings to know what are the newer technologies. Atul Mehta is one of the big guys. He's a pulmonologist in the US, and he talks a lot about endobronchial surgeries and electromagnetic navigation bronchoscopies. So what about natural orifice? We've spoken about endobronchial EMN. Couple of slides on natural orifice. The endoscopes have all gone into steerable endoscopes. So you can hold the endoscope and you can have devices coming at the tip. Okay, and you can actually catch a tumor and you can resect a tumor using a diathermy. You can do what is called as endoluminal surgery. So we are now getting into a domain of endobronchial lobectomy. So what you do is you come in via the bronchus, you come in there, you make an incision into the bronchus, your endoscope comes out, you look for your tumor, you clip, clamp, your whatever area is there, the tumor, you take it out, and then the tumor comes out, and then on the way out, you suture it. The way to take the tumor out is either by forceps grasping, bring it out, or by using liquid biopsy. So you put the tumor into a little pouch and you ablate it, and the tumor becomes cells, and you absorb the cell or you wash the cell back. And on your way out, as you're coming out, you put a couple of sutures into that area. So this is localized surgery for lung resection. You're not doing a whole lobectomy, but you're doing essentially a sub-segmentectomy or sub-segmental bronchus resection for small tumors. And of course, the last but not the least is the endoluminal robots. The endoluminal robots are really coming in a big way. There's a lot of work going on in endoluminal robots, and you will soon be able to operate without really being next to the patient. And the bronchoscopic robot will go in there, and the instruments will come out, and you will operate exactly as I showed you previously. So that is being called as a natural orifice surgery. So the reality is that things are changing fast. Things are changing really fast. The only thing constant in life is change. Most important. You've really got to be receptive to change. If you're still doing what you did 15 years ago, something is wrong. You've got to realize that things are changing fast. And the only people who survive are the people who are most responsive to change. If you change early and you adapt new technologies, chances are you will last a longer time, because you guys are young guys. You need to know this stuff, and you need to know what is possible in the future is going to happen now. So get involved with the technology from the word go, and you will make a huge difference. But remember, the technology is good. It looks all flashy, great, very sounds very, here's a guy giving you a teleconference about robotic endobronchial surgery, looking all sexy, nicely dressed up in a suit and all that. But the basics is the most important. Don't get carried away by the flashy bits. Understand that look beyond the technology. Don't forget, look beyond the technology. This is the basics of thoracic surgery. So don't forget open surgery. Open surgery still got a role in your management, but this is the future. Okay, this still stays the same. Thank you very much. Okay, guys, thank you.
Thank you very much, sir.
Thank you, sir.
It was a very long lecture, but it was really important. I covered everything that I could. Questions?
Quite interesting.
Sir,
Thank you very much.
Yeah.
Sir, one of your lectures you said something about endo finger.
What?
This lecture, sir, but in previous,
Endofinger. I don't know what is endofinger.
I heard it in your lectures itself. That's why
Really?
I didn't understand it perfect. Because
I don't remember endofinger.
Because it was come in our exams also. I couldn't find in one of your lectures in that midterm CMEs, Thoracic CMEs you had said future modifications. That's why
You may have misread it. I don't know. I don't remember using the word endofinger.
for this
I
tumor
don't know what is
localization, solitary for me not you.
I don't know. I'll have to look it up. I don't know where I said endofinger. It doesn't ring a bell in my mind, to be honest. Okay. Next question. I'll look it up, Arif. I'll tell you. I mean, this is a topic where I have researched extensively. I know exactly what are the new advances, everything that's happening. Endofinger is not ringing a bell. So let me look
I'm pretty sure I heard it in your lecture itself, sir. It's midterm Thoracic CME. It happened in Assam, Guwahati. And I had taken all their slides, pictures also, but I think I missed that one slide. I just can't remember. I'm pretty sure it was
not possible because I've been through 10 presentations to make this one. Okay, these are 10 presentations I've done over the last couple of years, which I put it together for you guys to understand everything in one go. Okay, just leave it with me. I'll see. I'll find out. It doesn't ring a bell, and if it doesn't ring a bell, means if I don't know what I'm talking about, then probably it's a misread from your side. I'll look it up. Next. 2.5 hours I spoke to you. You only have to come up with endofinger. Arif, kya re tu?
Sir, can I ask a question?
Fitun, come in. Tell me.
Thank you. Is there a role for endobronchial stent in pediatric cardiac surgery when, let's say, there is pulmonary hypertension pressing on the bronchus and the child failed to extubate? Is there a role for that?
We have used, not in pediatrics, but I have used endobronchial stenting in patients who have not been able to extubate as a temporizing method. I personally don't know about pediatric cardiac, whether it's been used or not. But if a patient is not being extubated because of polychondritis or tracheomalacia and things like that, we do use endobronchial stenting for getting the patient off the ventilator and then over a period of time trying to rid the patient of the stent. The problem is using a stent in a benign disease over a long period of time has a lot of complications because stents are foreign bodies in the airway and they cause irritation and they cause a lot of cough reflex. Patients don't tolerate them well. So using stents in malignant conditions are quite okay, but using stents in benign condition, you really need to be careful about the use. We use them for temporary situations, but they get
not
embedded.
For pulmonary hypertension, right?
I have personally never used it. I have never used it, to be honest.
Okay.
I have never used it in that situation. So honestly, I don't know the answer to your question. I'll have to look it up, but I have personally never used it. I've not come out into an indication where stents will help a pulmonary hypertension. I've never seen that.
I see. Okay, thank you.
But I don't do pediatric cardiac, so I will have to ask my colleagues. I don't know the answer to that.
Okay, sir. Thank you.
Okay. Yeah.
Thank you.
Anything else?
Is there a Sir Vikas? Yes, sir.
Yeah, Vikas, tell me.
In traumatic tracheoesophageal fistula, are we justified in putting a tracheal stent? And if yes, what is the length, sir? How long we can?
No. That depends on the size of the tear. It depends on the size of the tracheoesophageal fistula. We do use predominantly the first port of call is the esophagus. So you try not to, you don't do the tracheal side, you do the esophageal side. But if you're still getting leak around the esophageal stent, then you can go in and put in a stent into the trachea. But remember, in a chronic tracheoesophageal fistula, 2 stents and tissue between 2 stents gives rise to ischemia. That is the risk. You understand? If there's a solid thing on this side and a solid thing on this side, tissue between it actually doesn't heal that well. But temporarily you can use it, yes. But esophagus is the one I prefer. Whenever I have a tear or I have a tracheoesophageal fistula, I will predominantly put into the esophagus.
It will be a covered stent, right?
Covered stent, yeah, covered stent.
And is it a permanent solution or a time-buying measure?
Time-buying measure.
So you have to go in surgically later.
No. These things don't work with surgically. You hope it heals.
No. You, if you have put a esophageal stent, will you go later surgically to correct it? Put some pedicle wrapping or something? No.
Yeah, in the long term, you can do that. In a long term, that is, we'll talk about tracheoesophageal fistula managements at a later stage. I'll do that. I've got that talk ready actually. But in a long term, you operate on them, but not in an acute term, because acute term, they are always not good tissue to suture. They always give way. You can go in and operate, but they always give way and you get recurrence. So you use the stent to buy time to get the patient as fit as possible, and then in the long term, you go ahead and operate.
Sir.
Yeah, who's next? There are 3 people who are raising hands. 1 minute, let me see who's that. Who just said, sir?
Sir, Sundaram Pillai, sir.
Yeah, Sundaram, tell me.
Sir, during any endobronchial procedure, what are the precautions we need to take so that the debris doesn't fall onto the distal passage, distal airway?
The important thing is, whatever you do endobronchially, you always have to do a distal bronchoscopy and suction out. Debris falling is okay, but you have to suction it out. And you have to really, make. So one thing that you do is when you grasp it with a forceps, do not pull the forceps back into the bronchoscope, because that will cause the debris to fall off. So whenever you've grasped it with a forceps, you take the whole apparatus out as a whole with the grasper out, not in the channel, because the channel is small. But a little bit of debris will always fall. We always do a very good suction wash of the distal areas before we come out, always. So some debris will go distally, but it doesn't really matter.
I think what we wanted to ask is a distal protection device like vascular hygiene.
Sorry, I didn't hear that. Your voice broke.
Is there something? Is there something like a distal protection device like vascular people use in carotids?
No. In the airway, it doesn't matter. You've got so much airway on both sides.
Yeah.
The problem is you cannot go distally because there is obstruction in your way.
Already, yes, sir.
To put any distal protection device, you should be able to go beyond the obstruction. Most of the times you cannot go beyond the obstruction. It's a very narrow passage, and you can hardly put in a little guide wire through it, leave alone a catheter to put in a device. So most of the times we operate, go in, you start buzzing. You do manual debridement as much as possible, then buzz, and suck, and then you just deploy a stent. And then once you have deployed the stent, either you go through the stent and go distally and suck everything out. There is no way you can go distally because it's an end system. And,
yes.
There is no pathway to go distally.
Thank you, sir.
Okay. Yeah, next question. Who else is that? Jibril Khalil.
Yes, sir.
Hi, Jibril. Where are you from, Jibril?
I'm actually from Nigeria, but I'm doing my fellowship in Narayana Rabindranath Tagore at
Tell us.
So my first question is about removing foreign bodies. We had cases where patient developed hypoxia during the procedure and bradycardia following stimulation of the airway. Is there any guidelines concerning that? For example, when you use a rigid bronchoscope on a patient who is undergoing foreign body removal, like where you need to stop and if there's anything to give to reduce bradycardia which can develop from stimulation of the airway. And then secondly, the patients with massive hemoptysis. We know we used to use rigid bronchoscopes. Is there any new or out of these new procedures, any of them being used as a replacement for controlling this massive hemoptysis in this kind of patients, more especially those with TB? Thank you.
Yeah, good questions. Very good questions. Now, I deliberately didn't deal much with foreign bodies because I wanted to cover more of the newer technologies rather than speak about techniques of removing a foreign body. The bottom line is whenever I do a foreign body, I will always consent the patient for surgery. Okay, always. As a rule, that's my standby. In case things go wrong and I'm not able to do whatever I want to do, then my standby is plus minus open surgery. Okay, that's one rule of the game. The second thing is that in anesthesia, you really need a very good anesthetist. It is absolutely mandatory. I personally don't do foreign bodies under local anesthesia and flexible bronchoscopy. Because I'm a surgeon, I don't do it. My pulmonologist does it sometimes, but he's had a couple of issues, a couple of patients where he had issues. And so he now does it in my theater under general anesthesia. The other thing is I always try to put in, as you know, over the years that I've done flexible or rigid bronchoscopy, I always start with the rigid bronchoscope because the rigid bronchoscope gives you airway. The most important thing is airway. The reason why these people get compromised is because airway is compromised. Okay. If you are able to have ventilation, then everything comes under control. All the bradycardia and everything else that you get is because airway is compromised, because you're not able to ventilate. And so the one tool that you must use in your theater is a Sandler's jet insufflator. Okay, Jibril, I have a feeling that you may not have that in your setup. A Sandler's jet insufflator is mandatory. You should really not do all these complex endobronchial procedures, even including removing a foreign body without the presence of a Sandler's jet insufflator. The reason why a patient is compromised and why you had to pull out is because he was not being adequately ventilated when you sedated him or you put him under GA. The moment you use a Sandler's jet insufflator, no matter what the situation, the high frequency jet pushes the oxygen past any obstruction. So it is very, very important to have a jet insufflation on table when you're doing that. Of course, there are times when the patient is not hemodynamically okay, you have to pull out and come out and then wait for the patient and go in on another setting, on another day. You can do that. You don't want a dead patient. The bottom line is you want a live patient in and a live patient out. So for me personally, I am very happy to defer the surgery for another day to stabilize him a bit more. I'll get the cardiologist involved. If they want to use any medical therapy to stabilize the heart, I'm happy. But 90% of the times, the problem is ventilation, not cardiac. This is not a cardiac problem. It is a ventilatory problem. And so that's why I would suggest you must use a good anesthetist who knows how to deal with these situations. And you must use jet ventilator. That is the key, even when you're taking out foreign bodies. Now, there have been situations where I've had to open and take out some foreign bodies. Few in my experience, very few. Most of them come out by endobronchial techniques. But I don't do it at the same sitting. What I'll do is, though I've consented it, I will actually come out, let the patient stabilize, and then reschedule on another day in a more elective way. Because at that moment, if the patient is compromised and you start doing major surgeries, it's going to give you adverse outcomes. Okay, so that's the first answer. The second answer to the question: in massive hemorrhages, the real trick is to isolate, to protect the normal lung. You understand? That is the key. Whenever you're dealing with massive bleeding, your whole idea of getting in there, you cannot stop the bleeding. What you want to do is protect the normal lung, so that the patient can be alive. Why does this patient die? When you get massive hemoptysis, patients don't die because of volume loss. They die because they drown in the blood. Okay, so the best thing and the first thing you need to do is a double lumen tube to the opposite side. That's the first principle of massive hemoptysis is protect the normal side. So you can put in a double lumen tube on the opposite side, and then if you want, you can put in a bronchial blocker onto the affected side. And then you can do whatever techniques. You can do laser ablation if you see the massive. In a massive hemoptysis, you cannot see the bleeding. It's a very, very aggressive situation where you protect the normal side. If you protect the normal side and you get the guy through the night, next day you can operate and get rid of that affected side. Or you can do endobronchial procedures like adrenaline wash, etc., or bronchial blockers. You've got endobronchial glues for blocking of that bronchus and things like that. Or you've got surgical option. You can go in by surgery and you can take out that lung or that lobe if you've got an obvious pathology. But the philosophy of management is always protect the normal side, most important. So a double lumen tube is mandatory in these patients. Okay, thank you. Very good question.
Thank you.
Yeah,
Thank
who
you.
else? Any more questions?
Yes, sir.
Yeah, who's raising
Hello.
his upper range? Is it upper
Aspiration.
range?
Yes.
Yeah.
Yes, sir. Yes, sir. Sir, one question, sir. Is there any role of endoscopic elastography for procuring the yield or increasing the sensitivity or specificity of the EBUS?
Yes, there are some papers which have spoken about that. I personally don't know much about it. I haven't read those papers in detail, but I have actually read somewhere about this technique. But I personally have never, I don't know much details about it.
Okay, sir.
But it is there
Thank you,
in
sir.
some paper. I definitely came across this word being mentioned, but I don't know the details of the technique.
Okay, sir. Thank you, sir.
Yes, Sudhir Mishra.
Sir, what are your protocols in fire in the airway, other than the precautions what you told?
It's a disaster, I'm telling you. It's a disaster. I've never experienced it. Touch wood, I don't want to experience it. The protocol is that you stop all burning. That's the protocol, and you give steroids. You cannot. The fire is not a sustained fire. The problem is the burn that happens with the fire. So it is just one blast, which causes the bronchial, which causes bronchial mucosa burns, and the treatment is stop everything, start oxygenating, and give steroids. You have to give acute steroids, and this patient might need to be ventilated actually and kept in the ICU. So there is no, you cannot apply silver sulfadiazine to that. It is all supportive management. Everything is supportive management in airway injuries, airway burns.
Inhalational anesthesia, the agents are avoided.
Yes. Yeah, but more important is oxygenation of the patient. So the moment you get into that situation, you are in a phase where you want to oxygenate the patient. So you intubate the patient, take him into ICU, keep him intubated. I would give bang anti-inflammatories. I would give steroids, hydrocortisone, and things like that. So these are all supportive management. There is no real therapy
of that burn. Once the burn has happened, it's happened.
Thank you.
Yeah. Next question. Who was Shashikaran? Did you want to ask me a question?
Yes, sir. Sir, before deployment of all of the stents and you were telling about the glue also, you will be operating the mucus of the involved bronchus in all the patients, in all the cases?
Yeah, when I'm dealing with BPF, it's not a big operation. You just use a brush to lightly stroke the mucosa. It's not, you're not causing massive bleeding. Or, these are very tiny brushes and they are very soft.
I mean, what is the
The upgrade is so that
behind it?
the bronchus, so that the glue sets into the mucosa.
The raw surface, you're creating a raw surface for it to.
Yeah, that's what you're doing. There's nothing. It's not rocket science. It's just. It's not mentioned in any randomized control trial. It's just something you learn over the years.
I mean, how successful is the glue in cases of BPF, sir? Actually,
I have over the years used glue now 15 or 16 years, and I've got away with 4. And in 5, I managed to control the BPF, as in make the patient aseptic and settled and all that, and then did the surgery afterwards. So 3 or 4 I have got away with, but it's very hit and miss. It's a very hit and miss. Small fistula, non-septic patient with minimum soiling of the other side, you can do glue. But most of the time you do glue as a time buying technique where you don't want to go in straight away, because at the end of the day, the way I treat bronchopleural fistulas is I actually put in either omentum or I put in muscle and things like that. So it is quite a big operation to treat bronchopleural fistulas for me. So if the patient is septic or is not well, then I don't want to bronchopleural fistula to surgery. So I use the glue just to buy time.
So generally, will you
3 or 4? I think I can't remember the exact number, but I've had a few cases where I managed to get away with it.
will you freshen the area of the fistula before you close it, or
that is another topic altogether. I will talk to you about BPF. I'll talk to you about BPF. It's a very complex topic, and I have a whole talk on it. It's a very complex topic. So there's a lot of discussion within the context of BPF. Next problem of freshening edges is that you don't know where is the pulmonary artery underneath all that. That is the problem. So you got to be very careful when you're trying to put knife or scissors to the edge of the fistula. Somewhere in that mess is a PA. And if you cut into the PA, there is no control because everything is infected and it's a very, very bad situation. So you got to be very careful. The best thing is just plug it with a nice piece of omentum. But it's a whole topic by itself. I'll discuss with you.
yes?
Okay, Sanat Kumar, did you want to ask me a question?
Hello. Yes, sir. Good evening. Sir, this BVRS is only a bridge to the future surgical intervention like...
No. That it is now becoming primary treatment. More and more data is coming through that BVRS might be the primary. I don't think it's a bridge.
Oh, so...
It's not LVAD.
Okay, sir. So by doing a BVRS, we can actually avoid a bulectomy or LVRS nowadays.
But who knows? We don't know the long-term results. These are all new technologies.
Okay. Thank you.
Jibril's hand is still up. Did you want to ask something else, Jibril, or you're happy? Okay. Anybody else has any other questions to ask? There is some chat. I don't know what.
Sir, I don't know when you will be taking the BPF, but patients that have storm blower following bronchial surgery, say pneumonectomies, does any endobronchial procedure work for them?
Yeah, we'll talk about it. I'll talk to you when I talk to you. There's a lot of, it's a very complex topic. I don't want to just casually tell you something about an Amplant's device and all that. There is something called as an Amplant's device, which is used in BPF, but outcomes are not great. So I don't want to talk about that at the moment. When I talk about BPF, I'll give you all the... Some people have tried the umbrella device. But post-pneumonectomy, if you've got a BPF, you're in deep shape. You need to sort it out. Basically.
Thank you.
Okay. Thank you very much. Did it make sense, guys? Was it all right?
Yes, sir. It was wonderful.
Very fantastic.
Wonderful.
Today you have translated Latin and French into simple English.
What was that? I can't hear you. What is that?
Today you translated Latin and French into simple English.
Oh, good. See my cap, man, my lovely cap. I'm so pleased. I was sitting in the garden out there with the sun coming in my face. So I ran in.
Part of your PP for groceries.
All right. Thank you. It was fun. It's a very long lecture. This is probably the longest lecture I've taken for you guys. And it's worth discussing all these very complex.
Bye
Thank you,
bye.
sir.
Thank you, sir.
Bye.
Thank you very much.
What do you want next topic?
That chest tubes and post-operative space infection, man.
Post-op space-related issues.
Okay, give me a day or so. I'll see how I can
Sir,
work.
class on LVRS.
Okay. LVRS is okay. I've done that.
LVRS we have already done, sir.
Yeah, I think we've already done.
That class is there on YouTube.
Yeah, it's there on YouTube. I've done LVRS as far as I remember.
Yes.
But I think post-operative
Yes.
chest space air leaks, management and prevention of air.
Yes.
You're not done the LVRS in this lockdown marathon, sir. That's a
Arey, bhai. You know, I took out I made two folders. I bought a new hard disk. And on it, I made two folders. One was which I just realized is actually at 30 or 32. But we have not recorded all of them. And then I've got another folder, future lectures. And unfortunately, in future lectures, there are at least 50 topics, which I've given over the time, over the years. So, but the problem is for every lecture, I need to work, for one lecture, I work at least 18, 20 hours for you guys, because I have to go back and read everything. And, because some of you are exam brains, I need to be very careful about what I say. And everything has to be evidence-based. That is what I'm trying to give you, is actually recent evidence-based, not 20 years ago evidence. So I'm trying to give you the recent evidence. So I have to read a lot. And, I'm telling you, my wife is complaining. But this series is likely to stop soon. All right. Thank you very much, guys.
Thank you, sir.